device, used as an extracorporeal blood pump in cardiopulmonary bypass procedures for up to 6 hours. The pump is intended for use with the Terumo Advanced Perfusion System 1 and Sarnes centrifugal pump systems, or it may be used with Stockard Sorin centrifugal pump systems. The Capiox ICP centrifugal pump is a drop-in replacement for the Sarnes centrifugal pump. No adapter plate is needed when it is used with the LivaNova S5 and S3 heart-lung machines. The Capiox ICP centrifugal pump's design provides flows to 8 liters per minute and has a maximum pressure rating of 700 millimeters of mercury. Additionally, the max pump rotation speed is 3,600 revolutions per minute with a prime volume of 55 milliliters. The Capiox ICP centrifugal pump is pre-treated with X-coating, Terumo's exclusive biopassive surface coating. Because it has the same basic shape and performance as the Sarnes centrifugal pump, the Capiox ICP pump is a direct replacement in tubing packs. The pump features an efficient impeller design with molded-in magnets. Because there is no protrusion, the pump fits LivaNova drive motors. The Sarnes centrifugal pump had 11 parts and sub-assemblies. The new Capiox ICP centrifugal pump has only 5 components to reduce complexity while still meeting critical user needs. The Capiox ICP centrifugal pump uses the same proven connector barb design as on Terumo's Capiox FX oxygenators. There is a 2-barb design on the Capiox ICP centrifugal pump's outlet and inlet versus 3 on Sarnes centrifugal pump. This means there is less risk for tubing disconnect, although tie banding all connections is still recommended. It's important to thoroughly read all warnings, cautions, and instructions carefully prior to use. Contact your Terumo cardiovascular sales representative for more information or visit us online. Terumo's new Capiox ICP centrifugal pump with X-coating surface coating is a sterile, single-use device used as an extracorporeal blood pump in cardiopulmonary bypass procedures for up to 6 hours. The pump is intended for use with the Terumo Advanced Perfusion System 1 and Sarnes centrifugal pump systems, or it may be used with Stockard Sorin centrifugal pump systems. The Capiox ICP centrifugal pump is a drop-in replacement for the Sarnes centrifugal pump. No adapter plate is needed when it is used with the LivaNova S5 and S3 heart-lung machines. The Capiox ICP centrifugal pump's design provides flows to 8 liters per minute and has a maximum pressure rating of 700 millimeters of mercury. Additionally, the max pump rotation speed is 3,600 revolutions per minute with a prime volume of 55 milliliters. The Capiox ICP centrifugal pump is pre-treated with X-coating, Terumo's exclusive biopassive surface coating. Because it has the same basic shape and performance as the Sarnes centrifugal pump, the Capiox ICP pump is a direct replacement in tubing packs. The pump features an efficient impeller design with molded-in magnets. Because there is no protrusion, the pump fits LivaNova drive motors. The Sarnes centrifugal pump had 11 parts and sub-assemblies. The new Capiox ICP centrifugal pump has only 5 components to reduce complexity while still meeting critical user needs. The Capiox ICP centrifugal pump uses the same proven connector barb design as on Terumo's Capiox FX oxygenators. There is a 2-barb design on the Capiox ICP centrifugal pump's outlet and inlet versus 3 on Sarnes centrifugal pump. This means there is less risk for tubing disconnect, although tie banding all connections is still recommended. It's important to thoroughly read all warnings, cautions, and instructions carefully prior to use. Contact your Terumo cardiovascular sales representative for more information or visit us online. Terumo's new Capiox ICP centrifugal pump with X-coating surface coating is a sterile, single-use device used as an extracorporeal blood pump in cardiopulmonary bypass procedures for up to 6 hours. The pump is intended for use with the Terumo Advanced Perfusion System 1 and Sarnes centrifugal pump systems, or it may be used with Stockard Sorin centrifugal pump systems. The Capiox ICP centrifugal pump is a drop-in replacement for the Sarnes centrifugal pump. No adapter plate is needed when it is used with the LivaNova S5 and S3 heart-lung machines. The Capiox ICP centrifugal pump's design provides flows to 8 liters per minute and has a maximum pressure rating of 700 millimeters of mercury. Additionally, the max pump rotation speed is 3,600 revolutions per minute with a prime volume of 55 milliliters. The Capiox ICP centrifugal pump is pre-treated with X-coating, Terumo's exclusive biopassive surface coating. Because it has the same basic shape and performance as the Sarnes centrifugal pump, the Capiox ICP pump is a direct replacement in tubing packs. The pump features an efficient impeller design with molded-in magnets. Because there is no protrusion, the pump fits LivaNova drive motors. The Sarnes centrifugal pump had 11 parts and sub-assemblies. The new Capiox ICP centrifugal pump has only 5 components to reduce complexity while still meeting critical user needs. The Capiox ICP centrifugal pump uses the same proven connector barb design as on Terumo's Capiox FX oxygenators. There is a 2-barb design on the Capiox ICP centrifugal pump's outlet and inlet versus 3 on Sarnes centrifugal pump. This means there is less risk for tubing disconnect, although tie banding all connections is still recommended. It's important to thoroughly read all warnings, cautions, and instructions carefully prior to use. Contact your Terumo cardiovascular sales representative for more information or visit us online. Terumo's new Capiox ICP centrifugal pump with X-coating surface coating is a sterile, single-use device used as an extracorporeal blood pump in cardiopulmonary bypass procedures for up to 6 hours. The pump is intended for use with the Terumo Advanced Perfusion System 1 and Sarnes centrifugal pump systems, or it may be used with Stockard Sorin centrifugal pump systems. The Capiox ICP centrifugal pump is a drop-in replacement for the Sarnes centrifugal pump. No adapter plate is needed when it is used with the LivaNova S5 and S3 heart-lung machines. The Capiox ICP centrifugal pump's design provides flows to 8 liters per minute and has a maximum pressure rating of 700 millimeters of mercury. Additionally, the max pump rotation speed is 3,600 revolutions per minute with a prime volume of 55 milliliters. The Capiox ICP centrifugal pump is pre-treated with X-coating, Terumo's exclusive biopassive surface coating. Because it has the same basic shape and performance as the Sarnes centrifugal pump, the Capiox ICP pump is a direct replacement in tubing packs. The pump features an efficient impeller design with molded-in magnets. Because there is no protrusion, the pump fits LivaNova drive motors. The Sarnes centrifugal pump had 11 parts and sub-assemblies. The new Capiox ICP centrifugal pump has only 5 components to reduce complexity while still meeting critical user needs. The Capiox ICP centrifugal pump uses the same proven connector barb design as on Terumo's Capiox FX oxygenators. There is a 2-barb design on the Capiox ICP centrifugal pump's outlet and inlet versus 3 on Sarnes centrifugal pump. This means there is less risk for tubing disconnect, although tie banding all connections is still recommended. It's important to thoroughly read all warnings, cautions, and instructions carefully prior to use. Contact your Terumo cardiovascular sales representative for more information or visit us online. Terumo's new Cardiothoracic ICP centrifugal pump with X-coating surface coating is a sterile, single-use device used as an extracorporeal blood pump in cardiopulmonary bypass procedures for up to 6 hours. The pump is intended for use with the Terumo Advanced Perfusion System 1 and SARNS centrifugal pump systems, or it may be used with Stockard Sorin centrifugal pump systems. The Cardiothoracic ICP centrifugal pump is a drop-in replacement for the SARNS centrifugal pump. No adapter plate is needed when it is used with the LivaNova S5 and S3 heart-lung machines. The Cardiothoracic ICP centrifugal pump's design provides flows to 8 liters per minute and has a maximum pressure rating of 700 millimeters of mercury. Additionally, the max pump rotation speed is 3,600 revolutions per minute with a prime volume of 55 milliliters. The Cardiothoracic ICP centrifugal pump is pre-treated with X-coating, Terumo's exclusive biopassive surface coating. Because it has the same basic shape and performance as the SARNS centrifugal pump, the Cardiothoracic ICP pump is a direct replacement in tubing packs. The pump features an efficient impeller design with molded-in magnets. Because there is no protrusion, the pump fits LivaNova drive motors. The SARNS centrifugal pump had 11 parts and sub-assemblies. The new Cardiothoracic ICP centrifugal pump has only 5 components to reduce complexity while still meeting critical user needs. The Cardiothoracic ICP centrifugal pump uses the same proven connector barb design as on Terumo's Cardiothoracic FX oxygenators. There is a 2-barb design on the Cardiothoracic ICP centrifugal pump's outlet and inlet versus 3 on SARNS centrifugal pump. This means there is less risk for tubing disconnect, although tie banding all connections is still recommended. It's important to thoroughly read all warnings, cautions, and instructions carefully prior to use. Contact your Terumo cardiovascular sales representative for more information or visit us online. Terumo's new Cardiothoracic ICP centrifugal pump with X-coating surface coating is a sterile, single-use device used as an extracorporeal blood pump in cardiopulmonary bypass procedures for up to 6 hours. The pump is intended for use with the Terumo Advanced Perfusion System 1 and SARNS centrifugal pump systems, or it may be used with Stockard Sorin centrifugal pump systems. The Cardiothoracic ICP centrifugal pump is a drop-in replacement for the SARNS centrifugal pump. No adapter plate is needed when it is used with the LivaNova S5 and S3 heart-lung machines. The Cardiothoracic ICP centrifugal pump's design provides flows to 8 liters per minute and has a maximum pressure rating of 700 millimeters of mercury. Additionally, the max pump rotation speed is 3,600 revolutions per minute with a prime volume of 55 milliliters. The Cardiothoracic ICP centrifugal pump is pre-treated with X-coating, Terumo's exclusive biopassive surface coating. Because it has the same basic shape and performance as the SARNS centrifugal pump, the Cardiothoracic ICP pump is a direct replacement in tubing packs. The pump features an efficient impeller design with molded-in magnets. Because there is no protrusion, the pump fits LivaNova drive motors. The SARNS centrifugal pump had 11 parts and sub-assemblies. The new Cardiothoracic ICP centrifugal pump has only 5 components to reduce complexity while still meeting critical user needs. The Cardiothoracic ICP centrifugal pump uses the same proven connector barb design as on Terumo's Cardiothoracic FX oxygenators. There is a 2-barb design on the Cardiothoracic ICP centrifugal pump's outlet and inlet versus 3 on SARNS centrifugal pump. This means there is less risk for tubing disconnect, although tie banding all connections is still recommended. It's important to thoroughly read all warnings, cautions, and instructions carefully prior to use. Contact your Terumo cardiovascular sales representative for more information or visit us online. Terumo's new Cardiothoracic ICP centrifugal pump with X-coating surface coating is a sterile, single-use device used as an extracorporeal blood pump in cardiopulmonary bypass procedures for up to 6 hours. The pump is intended for use with the Terumo Advanced Perfusion System 1 and SARN's centrifugal pump systems, or it may be used with Stockard Sorin centrifugal pump systems. The Cardiothoracic ICP centrifugal pump is a drop-in replacement for the SARN's centrifugal pump. No adapter plate is needed when it is used with the LivaNova S5 and S3 heart-lung machines. The Cardiothoracic ICP centrifugal pump's design provides flows to 8 liters per minute and has a maximum pressure rating of 700 millimeters of mercury. Additionally, the max pump rotation speed is 3,600 revolutions per minute with a prime volume of 55 milliliters. The Cardiothoracic ICP centrifugal pump is pre-treated with X-coating, Terumo's exclusive biopassive surface coating. Because it has the same basic shape and performance as the SARN centrifugal pump, the Cardiothoracic ICP pump is a direct replacement in tubing packs. The pump features an efficient impeller design with molded-in magnets. Because there is no protrusion, the pump fits LivaNova drive motors. The SARN's centrifugal pump had 11 parts and sub-assemblies. The new Cardiothoracic ICP centrifugal pump has only 5 components to reduce complexity while still meeting critical user needs. The Cardiothoracic ICP centrifugal pump uses the same proven connector barb design as on Terumo's Cardiothoracic FX oxygenators. There is a 2-barb design on the Cardiothoracic ICP centrifugal pump's outlet and inlet versus 3 on SARN's centrifugal pump. This means there is less risk for tubing disconnect, although tie banding all connections is still recommended. It's important to thoroughly read all warnings, cautions, and instructions carefully prior to use. Contact your Terumo cardiovascular sales representative for more information or visit us online.
All right. So we start a very interesting session, co-chairing with Dr. El Savi, in a very important matter that relates to the function of the MiECTiS system and the patient itself, the blood conservation strategies. And we have very experienced commentators on the table with us. So let's start with the first talk by Monsieur Beaufreron, Dr. Beaufreron, who's going to give us 10 good reasons on reducing anticoagulation during MiECTiS.
Thank you, Mr. Chairman. Dear colleagues, ladies and gentlemen, first of all, I would like to thank sincerely the MiECTiS International Society for inviting me to give this lecture about 10 good reasons to reduce anticoagulation during MiECTiS. So usually anticoagulation is monitored by measuring a CT, and you can see what are the traditional guidelines about the dose of heparin that is initially administered to any patient, that is to say 300 units per kilogram. And SCT must be over 480 seconds to start a CPB. We all know that MiECTiS is an ultimate approach of OPEC, optimize extracorporeal circulation. So the question is reduced goal-directed anticoagulation a valuable option to minimize MiECTiS or optimize extracorporeal circulation? Number one, we all know that there is an increased preference for the use of arterial graft when doing CABGs, and you can see here, in fact, or on data among the last 20 years showing how many patients nowadays will benefit from bilateral internal thoracic arteries as a graft. But in the meantime, we are facing a lot of patients with an increased use of dual antiplatelet therapy due to modern incentives of cardiologists after acute coronary syndrome and preoperative PCI. And very often the operation cannot be postponed, and despite it would be recommended by the guidelines, but it is quite impossible to do on this way. So that will increase a lot the risk of major bleeding, as shown on this slide here. So second reason would be the silent epidemic of anemia that we can see nowadays. Up to 40% of patients are anemic before operation. And we know for a long time ago that hospitalization is a major contributor to this kind of anemia. So the problem is that it competes with anticoagulants to increase the risk of bleeding and transfusion. And in the case, it is associated to severe bleeding and transfusion rate over 75% and 50% respectively. This article gave some evidence that OPCAB was superior to ONCAB in those particular subset of anemic patients, mainly for two reasons. The first one was the target SCT that was reduced at 300 seconds versus 450 seconds, and also because of less hemodilution with OPCAB. As transfusion risk and adverse event is well known, blood transfusion following cardiac surgery has been shown to be independently associated with increased risk of major morbidity and mortality. And currently, from the last one of the last publications of the CTSNet database, we know that the transfusion rate in CABG patients is above 40%, and even more than 60% when surgery is combined, associating CABG plus valve surgery. It's even worse when using dual antiplatelet therapy, and I just want to emphasize this very nice article written and published by Balco and Nucci about the deadly triad of cardiac surgery, that is to say major bleeding, transfusion, and anemia. And you are probably well aware about the protein controversy. It was frequently used, this drug, as to control the bleeding under aspirin in the past, and was withdrawn after publication of a very controversial article in 2006. So therefore, the drug was introduced 10 years later, but I would emphasize this warning by Benedetto and collaborator in a post-hoc analysis of the ART trial about the early and late mortality that makes this aprocitentan not very the best solution for controlling the problem of bleeding after surgery. So now let's go back to the critical appraisal of the guidelines. You know that all the guidelines are based on the two articles written by Bull and collaborator in 1975. These two papers were based on 8 patients with a computer simulation, and the second one on 25 patients. But what is very interesting, if you have the possibility, the opportunity to read this paper, is to see that according to Bull and collaborators, a CT value below 180 seconds is probably life-threatening. Between 180 and 300 seconds, it is a questionable range of ACT, and it is safe over 300 seconds. He wrote that in 1975, and he also wrote that above 600 seconds, it is unwise. So when we go to general books about cardiopulmonary bypass, we can read that Bull recommended attaining an ACT over 480 seconds before initiating CPB because it provided a safety margin over the believed minimum safe ACT over 300 seconds. And that, after that, it appeared that many practitioners have misinterpreted their recommendation. So far, the baseline level of 480 seconds has been retained more and more in the guidelines without a scientific validation that would be adequate. Even in the last recommendation about anticoagulation, you can read that it is reasonable to maintain activated clotting time above 480 seconds. And this is, of course, based on the limited evidence. Even if you don't want to reduce the anticoagulation process, you may rethink the heparin dose in your patient. This article published 20 years ago shown that in more than 80% of the patient, if you just provide 200 units per kilogram of heparin, you're going to reach an ACT over 480 seconds in more than 80% of the patient. But in fact, they demonstrated that if you reduce this dose of heparin at the initiation of CPB, you will gain about 20% of blood loss after the operation. Even if you don't want to reduce the process of anticoagulation, just by reducing a little bit the dose of heparin, you will gain the benefit. So, because it's very important to consider that you don't have to expect anything better from the highest ACT you can get. This article shows elegantly that if you compare up pump surgery with an ACT at 250 seconds compared to old-fashioned CPB, then you can see that even at an ACT around 700 seconds and even also more than 1,000 seconds, that is to say it's not available, not assessed, then high ACT does not protect from the coagulation activation, since you can see the antithrombin complex would be very high despite the very high ACT. So ACT very high is not an expected protection against coagulation activation. At the end of the operation, the reduced goal-directed anticoagulation implies less protamine because you need a point-of-care device to achieve this protamine titration that would finally allow to avoid excess of protamine and promotes a better platelet aggregation, would facilitate the surgical field hemostasis. As a surgeon, I do appreciate that very much, and reduce also systemic inflammatory response. Another point which is very important that was reported by our friend Marco Ranucci is the interest to reduce anticoagulation because you're going to preserve the antithrombin 3. And the antithrombin 3 is in fact the physiologic anticoagulant because heparin, as you know, is not a direct anticoagulant, but just act by amplifying the antithrombin 3. So it's very interesting to see that if you reduce the anticoagulation under the protective effect of an heparin coating in that study, then you will reduce the decrease in antithrombin 3 postoperatively and especially at postoperative day 1 in ICU. And the last reason to maybe consider this approach is to realize that MiECTiS affords all the best to achieve reduced goal-directed anticoagulation. This is our protocol in our center. It's an OPEC, it's not really a MiECTiS because the arterial pump is not necessarily a centrifugal pump, but you can see that we use all the other parameters of such a MiECTiS program and optimization of CPB that finally tends to be similar to the MiECTiS approach. And as a conclusion, and last but not the least, I would just remember what I saw this morning on this presentation about the COMICS trial, that even in a MiECTiS group, the rate of transfusion was more than 30%, and that based on the evidence, reducing anticoagulation there is MiECTiS is to be, to my opinion, a valuable option to optimize in the future the postoperative outcome of patients beyond the clearly demonstrated benefit of this technique. Thank you very much.
Merci bien, Professor Profeton. It was a very interesting talk, and I think you have a lot of points about this, and the arguments are very valid. I think we should try and proceed with all the speakers for the sake of time and try and make a good conversation towards the end. Thank you very much. I'll pass on to my colleague.
Yes, so I'm honored to present the next speaker, Apostolos Deliopoulos, here from Thessaloniki. He's a perfusionist, and he's going to tell us something about blood conservation strategies from a perfusionist perspective.
Good afternoon, everyone. My topic is blood conservation strategy, perfusion perspective. There are a lot of studies said that excessive dilution with hematocrit less than 24 has been connected to be the cause of impairment homeostasis in terms of drop in coagulation and fibrinolysis of proteins. Moreover, is the principal contributor of organ dysfunction during cardiopulmonary bypass. So what could we do to conserve blood? The concept of patient blood management includes different strategies so as to avoid unnecessary transfusion. So the pillars that contribute that concept are minimize the circuit of CBP in order to avoid hemodilution, and second, implement to use components and blood conservation techniques in order to avoid, if not eliminate, transfusion of allogenic blood. And these are the tools that we have to do that. And before I go with what we have done, I want to emphasize that enthusiastic team approach is necessary, a proper communication and combination of efforts in order to have the desired results. Acute normovolemic hemodilution includes withdrawal of some of the patient blood volume at the beginning of CVP and replacement with crystalloids in order the patient loses diluted blood with less effect to the total red cell mass. This blood is preserved in OR and is infused to the patient at the end of CBP. And here we can see how it goes. There is an intervention of a biocompatible soft bag and the venous line. Before go in bypass, we open the clamp A here until the blood replace the fluid, the prime. Then close this clamp here in position A, open the clamp B here, and at the same time the roller pump is activated. We give vasoconstrictions to support the pressure, and we can get from the patient 1 liter of blood. Here's the contraindications of this technique, but the best benefit of acute pneumovolemic hemodilution is that we provide fresh supply of undamaged red blood cells, platelets, and coagulation factors due to elimination of roller pump and horing surface. Another technique of blood conservation is to miniaturize the cardiopulmonary bypass circuit by using the vacuum assisted venous drainage. We could minimize the length of the circuit as much as possible if the parameters allow that without compromising any safety. We normally use a low prime oxygenator with integrated filter. The oxygenator is placed close to the pump, replace the venous line to 380, monitor the negative pressure continuously, and we want the negative pressure not exist minus 70 in order to avoid hemolysis and creation of microbubbles. So when go on bypass and the blood hits our circuit, the clotting cascade is activated, and we can reduce this incident by using heparin or other anticoagulant factors, but also the biocompatible circuits which mimicking the endothelium and repelling platelets and not allow them to adhere to the tubing wall. There are different kinds of circuits using polymeric hydrophilic polymers without heparin or with heparin, with sulfate and sulfonate groups, which create a negative charge tube, which is going to repel platelets and not allow them to adhere to the tubing wall. And here we can see how it goes. Adithrovin binds to the specific structure of heparin molecule. This binding involves a minor conformational change that accelerate the activation of throvin and other anticoagulant factors. And finally, this complex formation is released, re-expose again the heparin molecule and preserving that way the anticoagulant activity. And here we can see the benefits of those circuits: less blood product use, shorter ICU stay, lower cost, less negative impact on defense system. If we compare the open reservoir with the closed type reservoir, the closed reservoir is has a main advantage because there is no air interaction. The centrifugal pump is pre-load and after-load dependent, has less fibrinolysis and performs better in a long-lasting period. Retrograde autologous priming can differ from center to center because the circuit as well as the pump, the configuration of the pump are not standardized. However, whatever technique is used, the primary aim is to replace the fluid with autologous blood in order to reduce hemodilution. And here we can see the effect of retrograde autologous priming. We can see here the effect to the hematocrit with prime 1.6 liters and here with 600 ml. Arteriovenous ultrafiltration nowadays has become a common strategy for reversing pulmonary and tissue edema, especially in patients with overloaded circulatory volume. The main advantage of ultrafiltration over the cell saver is that there is little or no loss platelets and clotting factors. Not only the heparin is removed by the wash process, but also plasma, platelets, and coagulation factors. The red blood cells that refuse back to the patient has a survival which is equal to the patient's own or homologous blood. 2,3 DPG is higher, and for this reason, oxygen carry capacity as well tissue oxygen delivery are higher. Sequestration involves withdrawal of heparinized arterial whole blood. This blood is kept in OR and refused to the patient, is not RAP or acute normalic hemodilution. And here we can see how it goes. We open here the recirculation line until the blood from the arterial line replace all the prime until this point, then close the recirculation line here, open this clamp here, and get about 1 liter from the patient. The anesthesiologist support with vasoconstrictions. The main advantages of sequestration are this: blood is not exposed to foreign surface area, and coagulation profile depicts higher fibrinogen and platelets count. Low volume or blood cardioplegia can reduce myocardial and tissue edema, reduces systemic hemodilution, especially in repeated dose, and for this reason, the oxygen delivery is higher. And here is our protocol. We can see how low are the doses. And here we have the MiECTiS philosophy. MiECTiS is a closed system. There is no reservoir. The patient hacks his own reservoir. Short tubing, avoid hemodilution. Shed blood is much better regarding inflammation, brain emboli, and integrity of coagulation. Centrifugal pump has less fibrinolysis and perform better in long-lasting period. Coating tubing are more biocompatible and because mimicking the endothelium. So all these features render the system to be in advanced level. Moreover, the prime volume is less and ACT is less. So what modular MiECTiS system offers is this: air handling, volume management, blood management, and a safety net to perform all cardiac case mix. Modular MiECTiS system integrates all the latest advantage in perfusion field. I could say that represents the latest evolution in perfusion technology, overcomes all safety concerns and all technical issues, offering compatibilities to perform all cardiac case mix, abandoning the conventional CBP. The truth is that this circuit offers circumstances of off-pump surgery, because the patient goes to ICU with high hematocrit, less derangement to his physiology, with low lactate, passing urine, is not bleeding, warm, ready to be extubated the very next hours. Viscosity is the most important physiological parameter, which ensures autoregulation, ensures capillary fields, preserving homeostasis in terms of dropping coagulation and fibrinolysis of proteins. Reducing hematocrit less than 24 is the most dangerous thing that you can do in your clinical practice. Preserving adequate hematocrit has a little effect to the flow, but you have a great effect at density of the capillaries, increasing diffusion capacity and keeps convection normal, meaning that preserve the perfusion distance short so as to have the maximal oxygen extraction ratio from the capillaries to the tissue. And here we can see a video of the microcirculation. We can see here the small lines are the original capillaries. We can see here that we have change in flow. Here we have pulsatile flow. You can see fast, slow, and we can see here what's going on when we go on bypass with the MiECTiS system. There is no different, but the flow is now luminar, but preserve all the capillaries. And this one, What happened when go on bypass with the conventional CBP? There is no red blood cells at all. Not just because of flow, but because of diffusion. Thank you.
Thank you very much. I have one question.
Yes.
Do you have a different transfusion trigger on CPB and off CPB? Or is it the hematocrit of 24 all the time?
Most of the times it's 24. We apply goal direct perfusion. First of all, we increase our flow in order to increase the oxygen delivery to go more than 272. This is the first step. But if
so let me rephrase.
Yes.
I'm trying to provoke you here.
Okay.
If you have a hematocrit of 21 and your goal-directed perfusion tells you everything is okay, will you transfuse the patient or not?
Yes.
Do you also consider to take other parameters in? If you, for example, you have a patient 25 years old, the hematocrit is 20, but the NIRS is okay, SVO2 is okay, lactate is fine.
If I have preoperative this hematocrit or no?
No, during.
So I will transfuse. With 20 hematocrit, I will transfuse,
okay.
Of course. Because the oxygen delivery will be too low.
Okay.
Even if I increase my pump flow.
This is a very bad situation to discuss it now, but don't tolerate anemia. It's very, very bad. GDP is just a marker. You see the insult into the ICU. So even if you accept low hematocrit, you will see that something happens. NIRS doesn't say anything. NIRS is a safety alarm. It will alarm when the insult will become, but the insult will not become with 25, 21 hematocrit. It will create gradually, and you can see it in the ICU. And the problem is, whenever you don't transfuse, you see that either the intensivist or in the ward, this patient is getting 2 times more blood just because after a couple of days, he is much more anemic. So do not leave the patient to be anemic intraoperatively. It's very, very, very bad performance. And I can see it so many times, and I can say it everywhere, that look at the literature. If your hematocrit is less than 24, if HB is less than 8, it's very risky. You can say a young guy, very good GDP, yes, but you can't control all this. So try to be on the safe side, and I can say 8 is the limit. Don't go less, it's not good. And use it to everyone. Apostle said the secret. Nearly everyone. Why is that? Why did he say that? Because if we have a nanogenarian, a guy who has a lot of comorbidities, we go higher. 27, maybe 28, we don't go to 24. These guys, they need very, very good periphery. And you can see when we have the microscan and we study the microcirculation, glycocalyx is absolutely gone with low hematocrit. It's nothing there. And we've done the studies, and we're about to process, and we will publish, and you will see what's going on into the periphery. Absolutely mess. So don't go low. It is not good practice, at least for me, and I'm convinced of it.
I want to add something. So when we perform a cardiac surgery, we create an oxygen depth. When this depth is recovery, has a fast recovery, then mortality, morbidity is low. But if as the time becomes longer, mortality is higher. Thank you.
I just have one question with respect to when you're talking about ANH. What exactly, patient population-wise, case-wise, what do you target for your ANH practice?
I didn't catch your meaning of your question.
So your acute hemodilution?
Yes.
When you do that, do you have a specific patient population, case, procedure that you're targeting when you're doing that practice?
Okay. You mean that when I perform, I get blood from the patient?
Yeah.
Yes. I have a target of preoperative hematocrit 40%. And I want this is for conventional CBP.
Yeah.
Okay. I want a preoperative hematocrit 40%. And I have monitor, take the blood, go on bypass. If the hematocrit is less than 24, give some amount of this blood back to the patient. So always I want more than 24. Even though I will go with gold direct perfusion, meaning that increase my flow.
Okay.
Okay.
Thanks.
Thank you very much.
Thank you.
So I think this symposium was so well designed because now the anesthetist will talk to us, who is actually the more appropriate person to learn from. Dr. Hajek is going to talk to us about platelet multimodal function monitoring. And I do remember we used to refer to the green sterile sheet between the surgeons, the anesthetists, as the blood-brain barrier. So we're now expecting the real brain to talk to us about coagulation. Thank you very much.
Thank you. Good afternoon, everybody. The talk is about platelets. Platelets are the very important part of normal hemostasis, not only primary hemostasis, but also in the face of propagation and amplification of entire coagulation procedure. The procedure is ongoing not only in vessels, but also in circuit. Common finding after bypass is thrombocytopenia, partly due to hemodilution, partly to blood loss. But there is also a significant platelet activation during the bypass. We have in clinical practice and very little option to mitigate the activation of platelets. One of these is limit or avoid to suction, and because the shed blood reinfused increases platelet activation and also platelet damage. And we have also some pharmacologic option to use antifibrinolytics that not only blockade fibrinolysis but preserve platelet activation through the PAR1 receptor. So that is empirically known that isolated platelet count above 50 giga per liter is usually not associated with serious bleeding, of course, in setting when patient is not on active antiplatelet medication. Bleeding is still issue for platelet. This is the one of classical model of bleeding prediction by Ivan Karkuti. There's the odds ratio for thrombocytopenia was higher. Surgeon is disappointed that usually say give more platelets, but in many cases, even if patient is on antiplatelet medication, the transfusion of platelets doesn't solve the problem, especially on ticagrelor. Ticagrelor is now very popular in cardiologists. In Czech Republic, many emergency medical physician in the case of chest pain administer ticagrelor, and ticagrelor is reversible inhibitor, and if we take some platelet transfusion, it inhibits platelets too. Cardiologist is very happy. The more is the better, and for anesthesiologist is the hard place. Many years ago, we in an observational study using thrombelastography, such a global test, we detect the platelet dysfunction about 25% during cardiopulmonary bypass and 15% after the bypass. But classical thrombelastography cannot discriminate between thrombocytopenia or platelet dysfunction. One relatively new option to protect platelets is sequestration, using some new generation of cell saver with very gentle centrifugation of plasma. We can reach plasma, platelet-rich plasma, which can be retransfused after the surgery. There are some clinical data. One of the biggest study is from Texas Heart Institute with using this setting, and it show some reduction of transfusion and reduction of bleeding. This is the paper from a group of Cyril Serik from Toronto. They measure platelet function by aggregation stimulation by ADP in different autotransfusion devices and show good platelet function. Couple of weeks ago, the group from France presented the new data with using the platelet-rich plasma sequestration, but very satisfaction with clinical parameters, but they don't explain how to measure platelet function. The options of measure of platelet function are also aggregation or some monitoring of some receptor expression on the surface of the platelet. One option is optical aggregometry. Also, we can use impedance aggregometry. There exists some multiplate analyzer. It can be used as a point of core test. There are the stimulation of different receptors for different substances that induce the platelet aggregation. There are the calibration curves and normal ranges. We can also use the modification of tone elastography for TEG platelet mapping. The principle is very similar. There are some activators, some inhibitors, and we can measure percentage of maximum amplitude aggregation. This method is formerly was not user-friendly because very time-consuming. We need two analyzers. Today there exists the new analyzer with cartridge. Its examination is provided to 10 minutes. This is the chromatographic detection of CD receptors, flow cytometry, CD receptors, couple of receptors on the platelets that interacts with some inductors of aggregation. And the receptors are not only on platelets, but also on microparticles. Microparticles are small plasma membrane vesicles shed from different cells upon activation or apoptosis. And platelet-derivated microparticles constitute the majority of the pool of microparticles. They are a source of tissue factor and as negatively charged surface assemble the clotting factor complexes. So I show you our data with platelet monitoring. We use platelet-rich sequestration in elective cardiac surgery patient with estimated cardiopulmonary bypass duration above 2 hours. It must be patients with good initial hematocrit above 35% because we remove 800 milliliter of whole blood before the procedure to avoid the effect of surgical stimulation and bypass such. We measure the aggregometries parameters and TEG platelet mapping. It was not on MiECTiS, it was on standard cardiopulmonary bypass with prophylactic tranexamic acid dose. This is our transfusion protocol. Platelet-rich plasma was retransfused immediately after surgery, red blood cells, if necessary, on operating room or ICU. And we use our institutional transfusion algorithm using TEG. This is a group of 30 patients, no differences in demography, no differences in clinical adverse reaction. Parameters of cardiopulmonary bypass, of course, the same. No differences statistically significant in transfusion therapy, no in outcome, but the aggregation. Before PRP transfusion on the bypass, the aggregation for ADP and ristocetin is good, but for collagen and epinephrine is very decreased. This is the situation in the processed plasma. Only ristocetin activated aggregation, it works. And this is after the transfusion. This is the trend to normalize, but not to the baseline. We repeat this study with some other measurements. It's a small study, 10 patients for platelet-rich plasma sequestration, 10 for control. No differences in transfusion, no differences in parameter of thrombelastographic platelet mapping. We measure also optical aggregometry. You can see the same results as above. The partial protection for ristocetin and ADP. Flow cytometry parameters, there are some activation of receptors in the separated plasma, but at the end of the surgery, there was no differences. And interesting, very huge activation on the microparticles. So, I must conclude this is difficult to measure platelet function in vivo. Nor aggregometry nor thrombelastography is not primarily developed for the measure of platelet function. It was the forced aggregation. It is good for the test of antiplatelet therapy, not for situation in vivo. And if we take the platelet-rich plasma sequestration as a part of blood conservation therapy is in question. We have clinical data that are good, but we have in doubt about the real function of transfused platelets. Thank you.
Thank you very much, Dr. Hazek. This is impressive research that you showed us. Just a very quick question then. So your bottom line of your intraoperative management is really not ready yet. It's a matter of research, do you think? Or what do you do in your day-to-day practice?
We don't use it in the daily practice. We use only red blood cell sequestration, no platelets.
Thank you very much.
So it's a pleasure to present the next presenter. We're a truly interdisciplinary session, so it's rarely to have a cardiologist here. Dr. Bampali from Greece is going to talk about the trajectory of coagulation management, perioperatively, current practice, and future perspectives.
Thank you very much. Good evening, dear colleagues. It's a great honor and privilege to be in this session. To start with, there is this continuum axiom that cardiac surgeons are afraid of bleeding and cardiologists are afraid of thrombosis. To be honest, being an ICU doctor, I have to say that I'm afraid of both. It's a very tricky balance, and I have to admit that perfusionists and anesthesiologists are fearless. The typical surgical candidate has this labyrinthous cascade of clotting process. He takes antithrombotic drugs and he has at least 2 significant comorbidities. So balancing between bleeding and thrombosis is really difficult. We do know that MiECTiS technology has the ability to decrease hemodilution, transfusion, serious inflammation, and bilateral segregation, which means that we have a less risk for heart failure deterioration, risk for less risk for pericarditis, less risk for post-operative atrial fibrillation, up to 30%, like Dr. El-Safi told us before, and less risk for thrombogenicity, which means that we have better organ and tissue perfusion and preservation of the renal function. There are some non-modifiable risks regarding the target to decrease RBC transfusion, which is the gender and the age. And of course, we have on the contrary the paradox, the obesity paradox. But the rest are in our hands in order to reduce RBC transfusion. At the preoperative period of time, we have to be a proper prepper. You have to know the patient, especially the kidney function. We have to correct anemia, and you may use intravenous ferric approximatol, and of course, correct renal function by withdrawing nephrotoxic drugs. You have to know the comorbidities that affect thrombotic and bleeding risk, like kidney function, diabetes mellitus, heart failure, atrial fibrillation, rheumatology disease, or cancer. You may use scores to delineate these risks, like ARC-HBR criteria or even the frailty score. You have to know the drugs because we have now novel drugs like Cangrelor and they have elimination time. You have to know the drug-drug interaction because some drugs like non-CCBs that are currently used by the cardiac surgeons may increase the Beckett's effect. You have to be very careful with the breathing and define the time of antithrombotic drugs discontinuation. You have three options. You may wait, you may use platelet function testing, or use antidotes. In that case, you have to know the antidotes that you have in your department if the surgery is urgent or emergent. For example, the rituximab is applicable to in almost every hospital, especially in my country. You have to stop on time. Regarding antiplatelets, you may maintain low dose of AZA during the perioperative period if the surgery is non-emergent. If it's a non-coronary cardiac surgery, or the patient refuses to transfuse, or it's a high bleeding risk, you may stop aspirin up to 5 days prior to surgery. Regarding P2Y12 inhibitors in non-emergent cardiac surgery, you have to postpone the surgery for at least 3 days for ticagrelor, 5 days for clopidogrel, and 7 days for prasugrel. You may use platelet function testing if you want to guide decision with a less level of evidence. Regarding the coagulants, antagonists of vitamin K must stop 5 days before the elective cardiac surgery and targeting INR less than 1.5. Regarding DOACs, you have to stop them up to 48 to 96 hours prior to the surgery based on GFR and the regimen. You can see here in this nice demonstration by the post-trial by Dr. Ducatis from the States. Regarding breeds, you must not breed P2Y12 inhibitors or aspirin with low molecular weight heparin or fondaparinux. It's a totally different drug. You do not offer nothing to the patient, you just increase the bleeding risk. So you stop the drug and wait. Also, you do not breed antagonists of vitamin K unless there is a very high thrombotic risk, for example, a mechanical valve or severe mitral stenosis. You have to stop the VKA, wait, and proceed if the INR is less than 1.5. You do not breathe also when you stop DOACs unless there is a very high thrombotic risk. If you must, in some cases, breathing with 2B3A or intravenous Cangrelor, then the only option is if the patient is of a very high ischemic risk within 1 month of a STEMI or PCI, or if there is a history of stent thrombosis. You may stop Cangrelor 1 to 6 hours before the cardiac surgery, and the 2B3As 4 hours before the cardiac surgery. If you decide to breathe, use preferably anafraction of heparin. It's more, it's not easy to use, but you have a way to monitor it. Only if the INR is less than 2, and of course avoid fondaparinux. In this case, stop classical heparin 6 hours before the cardiac surgery, or the low molecular weight heparin 24 hours before the cardiac surgery. Intraoperatively, the management is very tricky, it's beyond my field. It's already been told very extensively by this summit. MiECTiS technology by itself, it's a very high asset in all spectrum of cardiac surgeries that preserves blood loss. We have a lot of point-of-care testing that facilitates individualized heparin or protamine management in order to prevent, rather to correct, perioperative bleeding. At this point, I want to highlight the enormous scientific work by this Center of Thessaloniki by Professor Anastasiadis, Antonis, and Argyriadou. Of course, there are new rising protocols targeting less threshold for ACT, for example, 300 seconds, and some new technology. But in the post-operative management, where we can do a lot of things, you should start aspirin within 24 hours after the surgery if there is no bleeding concern. Also, you may start P2Y12 inhibitor postoperatively within 48 or 96 hours regarding the initial cause of the surgery. You may resume Cagrelor, which is an intravenous drug, within 12 hours after the surgery, and restart ultrafractional heparin 12 to 24 hours post-surgery, low molecular weight heparin 24 to 48 hours post-surgery, and DOACs, you have to wait until 72 hours post-surgery, and then you have to stop the heparin. By guiding this nice table from Professor Duketis. Regarding VK antagonists, you have to wait 24 hours post-surgery, then bridge with heparin, and stop then when the TTR-INR is on target for 3 days. Some tips beyond the proper drug management. Remember drug-drug interaction. For example, paracetamol may increase VK effect. If you have to combine therapies, the less the merrier, which means that you have to do this for a shorter duration, use lower dosage, de-escalate if possible, and of course, redefine the original indication. Correct anemia with intravenous pericarboxymaltone, which gives you the ability to postpone RBC transfusion and wait. Remember heat, it's quite common, especially type 1. In that case, you have to change low molecular weight heparin with fondaparinux for thromboprophylaxis. Remember that there are several antibiotics that induce thrombocytopenia, like glycopeptides, that are very usually used in the post-operative era. Check often GFR and adjust the dose of drugs, avoid non-steroids, and assume high dose of statin as a stabilizer. As for future perspectives, we in the future may have one antidote that will coagulate blockage, also for heparin and DOACs. Currently, there is in phase 3 the drug siraparatan, and we wait the result of those trials. We may see new devices and graphs like the Onyx technology. Genotyping is also a possible perspective in order to find the optimal drug choice and combination and personalize the coagulation management. We may broaden point-of-care testing, even in the outpatient area, in order to address the platelet aggregation of the patient and guide better the antithrombotic therapy. Artificial intelligence is a new rising way to engrave the optimal drug choice and by using predictive analytics and standardized protocols. And of course, MiECTiS technology by itself, by broadening its utility, it's a very nice way to facilitate coagulation intraoperatively. And maybe in the future, we may see even more advances. Until then, you have to follow the guidelines and believe that the less is the merrier. Thank you very, very much.
Thank you very much. Are there any questions from the audience or the panel?
Thank you very much. This was very useful. I would like to ask Professor Beaufreton a question, really, if I may. We know how vague the ACT measurement is in terms of controlling what's really happening, but it's a very useful tool because we have it there in the operating room. Do you think, as most of the data are old on the safety margin, now with all the newer methods of assessing multiple stages of the coagulation, especially on the intrinsic pathway, do you think that, and Professor Anastasiadis may respond in that too, there is space for new trials, especially on the MiECTiS system, to actually check? Because my clinical experience, maybe because I'm just too impatient nowadays, is most of the time, as you mentioned, when I reach 350, I have a little quarrel with my perfusionist saying, go on. And he keeps saying, as you say, no, I said, my responsibility, go on bypass. And this is very anecdotal, but in a few thousand cases, we never really faced a problem, while we have this vague idea that when we are high, towards the end of the operation, we're struggling to get things back together appropriately. Of course, most of the time in conventional systems. So do you think there is lack of evidence with current literature? That's the question.
Yes, I thank you for your question. Yes, of course, I think that we could improve the knowledge by having more new studies and that. To my knowledge, I think that except the study of Adrian Bauer, comparing low ACT 300 seconds to regular ACT, I mean, regular between brackets, of course, and he demonstrated the benefit of that approach. We have to think and to realize, remember that the guidelines we are using are probably built on moving sense. I mean, there is no huge evidence, strong evidence to justify such elevated ACTs. So we are, when using a MiECTiS, giving to the patient all the best that we can do. I mean, closed circuit control of pericardial shed blood that is eliminated, which is very important, you see, very, very important to avoid clotting. I mean, sometimes it happens in my practice that I see some clots in the pericardial cavity. I'm not afraid of that because I know that what is a coagulation is a pericardial cavity has nothing to do with what is present inside the circuitry or inside the bloodstream of the patient. So we have to increase our knowledge about that. And once you have a good knowledge of this pathophysiology, and which is probably the case of every attendees of this meeting, but maybe not all the surgical community, then it is possible to go furthermore. And in the situation where we are facing many, many patients with double antiplatelet therapy, it's very important to avoid such an explosion of the transfusion rate.
Thank you very much. Thank you. We have commentators. Dr. Saridou is here and would like to make a comment. No? She's on duty, maybe. Dr. Jenny or Dr. Janse would like to add a comment.
I have also a question about the low ACT. I know that Adrian Bauer, he used a type 1 or a type 2 completely closed. And we know even for ECMO, it's quite an ECMO. And with the experience from ECMO, sometimes we also went on ECMO without heparin sometimes, and it worked because it is completely closed. But do you think if we go with a type 4, for example, would you also, do you have some data or a recommendation from your side in which region we have to go with the ACT?
May I comment on that? Yeah, first of all, Christoph said there is Bauer's paper. Last year, we published a paper with 132 patients from MiECTiS with low ACT. So have in mind, Hans-Jörg, that type 4 is type 3. It is always closed. It is like all the rest of the closed systems. That's why we go as low as 300 for CABG cases and 400 for all the rest of the cases. It's type 3. So when we say type 4 opens only if you have to do it. For example, an expected scenario, when you do a cardiac, an arrest for circulatory arrest for doing heart surgery, only that. So with this low ACT protocol, go and review our paper. We had no problem, and actually, our bleeding problems postoperatively are much less, and the protamine use, which is the most significant thing for us, was very, very low. So if we say type 4, we normally say type 3 circuits with low ACT, as I don't know who pointed out, I think it was Christoph, avoiding shed blood and have no blood-air interaction is completely safe. And we can prove that with our studies.
Thank you very much. Professor, would you like to? Yes.
Yes, in my practice in our hospital, since 20 years, we use for CABGs type 3-like system for CABGs. There is only a salt shell reservoir, and that's all. And we reduce the target ACT to start the CPB at 250 seconds. We are submitting currently an article with more than 3,000 patients operating on with this program. And I can tell you that this is very safe. There is no problem. For the valve operation, it's a little bit different. We consider the impact of the blood-air interface in the reservoir, the arterial reservoir. This is the reason why we increase the ACT at 350 seconds. But we do all the surgery like this. I mean, aortic valve surgery, mitral valve surgery, everything like this, except the CABGs with a lower ACT. So the only issue I would like to to think about and to emphasize is if you do valve surgery and you use CO2, which is a highly thrombogenetic gas, then maybe you have to be very careful for that. This is the reason why I never use CO2 to the other heart, because in addition, it will open the vessel of the brain and promote some strokes. So I'll be very careful with that. But for regular patient, because we are talking for most of the regular patient, I mean, this protocol is safe. And once you understood all the major parameter of blood coagulation and hemorrhage, then you are successful. It's really a question of philosophy, physiopathology, more than a question of device that is provided by the industry. You have to adapt yourself.
Thank you.
To make myself clear to Hans-Jörg, when we have to open the system, in that situation, Apostolos always gives heparin, always. So gives heparin, open the system, we go up to 500, and then we open the system immediately. Otherwise, when you go to type 4, you need to give heparin. We have not tested low ACT 300. When you open the system, as Christoph pointed out, we always give heparin, give heparin, and then he opens, always, immediately. Otherwise, it's dangerous. So you then open, suck from the set blood, then might create a disaster. So
That was the question,
yeah. But we operate on type 3. As Ashraf said, we made we created a chaos to the literature. Type 4 is a readily available hybrid system. But when we normally operate, it's type 3. We don't open.
The question was exactly that. If you open that.
Oh, absolutely. No. Always, Before opening, he gives heparin, he's here. Gives heparin,
Okay.
then.
Thank you very much, Professor. Any more comments from the panel? This was a very interesting session. I think we need to conclude here because there's another interesting session coming up with the interesting. Thank you very much.
Thank you. Make a good trip back. To Vladimir, all the best wishes.
Yes, thank you.
On the stage.
and gentlemen, it's a big honor for me to open this session. For me, it's like a family meeting. You know, I really like to have you here, and I hope we can discuss a bit, and we will show you what you show. And after, we like to discuss a bit as friends and colleagues. Yeah, thank you very much. The first speaker will be Sevada, please. Yes.
So, now? Yep. Awesome. So good afternoon, everyone. My name is Sevada. I'm from Medtronic. And before starting, I want to congratulate the Society for the 10 years anniversary. It's really great to be here. And I was here in Thessaloniki as well when it started. So really, really nice. And in fact, talking about anniversary, this year, actually last week, was also the 75 years of Medtronic since 1949. So I'm not mentioning this only for the number. I'm mentioning this because the start of Medtronic was a collaboration between physicians and engineers. And with Dr. Lilihai partnering with Buck and our founder is what started the company. And in fact, that's what we're trying to do also as we are here, trying to be supportive. He was a cardiac surgeon, exactly. So it all makes sense. And I think that's really why I wanted to start with this, especially in times of anniversary of the society. I think it makes sense that we continue collaborating together. And in fact, talking about what we are doing in cardiac surgery at Medtronic, so our vision is really to be able to cover both the surgical side and also the extracorporeal circulation side. So as you know, we have multiple of our products, and on the extracorporeal side, we also have cannulas, cardiopulmonary blood management, and we are expanding towards extracorporeal life support. And really, what we aim for is making sure that we bring innovations in your hands, evidences, and in fact, that's also what we talked about earlier today with the society members. How do we make sure that once this clinical data exists, how do we promote them, right, to advance the therapy? And of course, medical education, I'll touch on that in a minute. So there are a few products here that we've launched that were dedicated to extracorporeal therapies in the last few years. And in fact, I joined Medtronic when we launched Fusion. Mike was here, obviously. We've done that together. And in the last few years, we've been also focusing on trying to expand that towards not only perfusion per se, but where perfusionists are going. So it's very important for us. So as much as what trying to cover the clinical aspect and the patient outcome on the whatever is related to perfusion, we're trying as Medtronic to also go towards where the role of a perfusionist goes. And we know that the role of a perfusionist is not only in the OR, it's expanding also outside the OR. And there's many responsibilities besides being behind the pump that this profession is doing. So in that sense, the now and the future are three things that we're focusing on. The first one is obviously we wouldn't be a partner in the industry if we didn't bring solutions, technology solutions in your hands. So obviously, we're trying to bring innovations with internal developments, but also with specific partnerships that we do with other companies. I'm sure you've heard of a couple of them. I'll talk about one in a minute. The second part is something that I really don't want to neglect, and I want to reinforce every time I get a chance to talk, is the fact that if we want to be a partner for you guys, we need to be reliable. And that also comes from the fact that it's not only innovations that are important, but it's also the products that you are using every day that we need to make sure that we bring in your hands. And that goes through investments in regulatory requirements. I think every company here would agree about that. But also, since many things are happening in the market, we need to do some types of adjustments and investments to make sure that we control how we are bringing products in your hands through supply and production. And that's also by doing multiple vertical integrations of our operations to be able to do that. I know you probably somehow are affected on a daily basis by supply challenges, and that's something that we truly invest in to make sure that we improve that. And the last one is training education. That's something that we've been doing for a while, and that we're trying to optimize to use different channels to be able to bring it in your hands. And I'll give a couple of examples in a minute. But really, these three pillars are what we are focusing on now and also in the future. Really talking about innovations, we are launching right now our MiECTiS next-gen multi-stage. So it's the multi-stage version of a product that we launched about almost 10 years ago. And it's a product that is very well fit into strategies when we talk about minimal invasive access. So it's a product that works very well. I'm sure you'll hear about it very soon. So it's now available, the MiECTiS next-gen multi-stage. And also the partnership I was talking about, investing internally is one thing, but also partnering with experts that are focused on certain type of technologies, have the knowledge, has the experience in the past. Our partnership with MC3 allowed us to actually bring a lot of products that you see here on this slide. So we started with Crescent, the dual lumen cannula. We launched Nautilus and Nautilus Smart as the oxygenators. We have MiECTiS Life Support and Opus as well. And it's not yet CE marked, but we're going to have Crescent ride Atrium for pediatric VV usage. So it's not CE marked yet, it's going to come soon. And then the question is, then what, right? What brings all of this together? We are working and we're bringing a console to actually be the hardware that brings everything as a solution for ECMO in the coming future. As I mentioned, Crescent RAs may be very small in terms of number of patients on the market, but it's a very important pediatric cannula that will actually save a lot of patients across the world. And again, it's not CE marked yet, but it's a product that we want to talk. So as soon as we're ready to bring it on the market, that is adopted very quickly to make sure that we bring back those VA cases for respiratory back to VV, so we can avoid any issues in carotid cannulation. And the last part that I was mentioning is the trainings. Investing in trainings is very key. And we have different types of trainings, and we are trying to partner with experts in the field to be able to do that. Flow physiology course is something that has been known for a very long time now, that we continue to do both in person as well as in virtual reality. But we're also partnering with hospitals like UZ Leuven for ECMO, but also the Aristotle Hospital in Thessaloniki for MiECTiS classes. So I really encourage you that if you're interested to really be trained by experts, please come through us. We're going to put you guys in contact with experts to be able to learn about it in the practical side after having seen the clinical evidence of what this brings. And of course, whenever we have events, and we didn't get a chance to do that to this year, but we're definitely taking the opportunity whenever we have our perfusionists, cardiac surgeons, anesthesiologists, intensivist partners gathered at a conference, creating workshops to be able to do trainings. That's something that we do on a monthly basis. These are a couple of examples that we've done at Euro also. So really, we try to bring all of this together, not being only a product that is our interest necessarily to sell, but is really to partner with you guys by doing, as you see, a lot of different collaborations, going through educations and also clinical evidence promotion and things like that. Thank you very much. Thanks for the opportunity.
Thank you very much, Sevada. Thank you. Next speaker will be Andreas Becker from Terumo. Please, Andreas.
Yeah, let me also take the opportunity and congratulate the MiECTiS Society to 10 years. It's an amazing development, amazing history. And thank you for giving us the opportunity, as always, to present during this meeting. I thought I take this occasion also as an idea for my presentation and look for advancements in minimally invasive perfusion equipment and techniques during the past decade, to see how MiECTiS potentially is changing our way of working and also changing the equipment. As we all know, MiECTiS is about improving biocompatibility and reducing adverse effects of cardiopulmonary bypass. And we also have seen the recommendation in the guidelines several times before, I believe. There are three. So mainly MiEK is recommended in terms of reduced blood loss and the need for transfusion over conventional CPB, and also to improve the biocompatibility. Do we see that MiEK is replacing conventional CPB on a wide scale? Probably we are not there yet. There are certainly, there is increased interest, but I don't think, and also some presentations before mentioned that we are lagging a little bit behind in the adoption rate. The third recommendation actually caught my interest, and this is to use a combination of MiEK features to improve conventional CPB. And I believe to that aspect, we see activities on many levels. And so I screened literature over the past 10 years. It's certainly not a complete analysis. It's also subjective, but I hope it gives a good representation what happened during the past 10 years. So the first point I would like to mention is an obvious one, and I believe many centers revised their circuit diagrams over the past years, looking to reduce tubing lengths or also looking to change tubing diameter. Here as an example, I just put one paper where the standard half-inch venous line was replaced by a smaller 3/8-inch venous line for patients up to 80 kilograms, just using gravity drainage. And alone this change resulted in a significant reduction in red blood transfusion. So quite remarkable. And I'm sure many centers did these activities. Some clinics were even going further and combined different types and sizes of oxygenators with different tubing size. Also during the past decade, I believe small adult oxygenators have become more popular. So on top of the full-size adult oxygenator, there were smaller products developed that are ideal to perfuse smaller patients. And there is one example again here from the Mayo Clinic using this approach. And they created a decision tree where, based on the calculated blood flow of the patient, different oxygenator sizes and also different sized tubing was used with big success. So especially for smaller adult patients, this concept resulted in a reduction of transfusion needs and is certainly beneficial. By the way, this FX15 small adult oxygenator, this is also the oxygenator we had in the RockSafe system. So this is also a very unique product that can be used in MiEK closed circuits. One additional point that is, I consider part of the MiEK DNA is the use of autologous priming techniques, also to reduce the volume of crystalloid priming solution. Also, this, meanwhile, is listed in the guidelines with the highest class of recommendation, class 1, level A. I remember 10 years ago, I believe this was still discussed controversially. But meanwhile, there is enough clinical evidence to have this high recommendation. Again, just as an example, one paper where a special technique is used, the hematic antegrade repriming, and it was shown in this study that this reduces transfusion requirements, also inflammatory response in terms of extended mechanical ventilation. It saved cost and is a safe technology. Now, moving to a different topic, this goes more in the direction of reducing inflammatory response, and this is about removal of gaseous microemboli or also particles. And I remember Mike mentioned it already yesterday in his great presentation. This is the use of integrated arterial filter. This is beneficial in many ways. It not only helps to reduce priming volume, because now the filter doesn't require own housing anymore, has no own priming volume, or is adding very, very little priming volume to the oxygenator priming volume. It also reduces foreign surface area because, again, there is no arterial filter housing anymore, and it even improved GME removal. So this, in my eyes, was one of the most important advancements in oxygenator technology in the past decade. Then something that looks small, I still want to mention it because I was so impressed what difference it makes in the end. It's the introduction of curved venous inlets on oxygenator reservoirs. And I believe that the credit here goes to Medtronic.
Yes,
right?
it does.
I believe Medtronic was first introducing this with the Fusion. When I heard about it, I was like, come on, this is really a small thing.
Yeah.
What can it change? And when we also adopted this with the Cardiothoracic Advanced Oxygenator, I was so surprised how much this improves the air elimination in the reservoir. It's simply that the curved inlet allows a laminar flow and air bubbles stay intact. They are not dispersed because of turbulence. This is happening with the angle design, creates turbulence. Large bubbles are dispersed and many small bubbles that are very difficult to remove. With the curved inlet, you see on the diagram on the right side, it really makes a difference. We at Terumo believe that when we want to do less invasive perfusion and a more physiological perfusion, it requires real-time monitoring device. Here we are strong with the CDI monitoring platform. It's very well established, exists since more than 30 years, and also clinically well proven. There is this landmark paper from Trowbridge and colleagues showing that keeping the blood gas parameters and other blood parameters within physiological range reduces complication rates, reduces ICU stay and hospital stay, and so improving patient outcome. The CDI monitors 12 essential blood parameters, some of which are unique, like the potassium, the pH, and base excess. Since the launch of the CDI 550, we have also implemented goal-directed therapy, which also is part of the MiECTiS approach. So we included DO2, VO2 parameters. And again, goal-directed therapy is recommended with class 1 level A in the European guidelines. I'm today pleased to inform you that we are about to launch the next generation CDI now. It's called CDI One View. And just 2 weeks ago, we obtained FDA approval for this new device. You see in red, unfortunately, we are still missing the CE mark, and due to MDR regulation, this has become a lengthy process. So it will still take a while, we assume a year, approximately, until we will have this in Europe. What is new? Obviously, we kept the goal-directed therapy, included one more calculated parameter, the O2 extraction ratio. The device is future-proof. It allows implementation of additional parameters once they become available. It has simply a more modern look. It has a touchscreen display, is a modular setup. The processing core is separate from the display and can be mounted behind the heart-lung machine where it is not in the way. All of you using the CDI, you will know that service is not so easy for the CDI. If a probe breaks, always the monitor had to go to a service depot for repair. And this is why we now designed it in a way that it is plug and play. So if now a probe breaks, you can simply unplug it yourself and plug in a new probe, and you can go on. There's no need anymore to send in the devices for service. So this will greatly improve also the user experience. And finally, transport will get faster because we have slightly reduced the size of the calibrator and the gas bottles, and gas bottles can now be shipped by air, which was not the case before. Only sea and road transport, which is obviously slow, was possible. One last device that I would like to show, and I did that before, is endoscopic vessel harvesting. And this, even so, it has nothing to do directly with the extracorporeal circulation, I still think this can be an integral part of a bypass operation, a minimally invasive operation. And looking at the images, I believe it's very clear what I mean with minimally invasive. Alone, the cosmetic result is far better compared to open vein harvesting or even the bridging technology. And there are numerous benefits for the patient and also for the clinicians, like reduced wound healing, less pain and shorter hospital stay, simply lower incidence of complications. It's also for the clinician offering excellent vein quality or vessel quality, and it is also cost effective. When I say cost effective, you may question that because we hear many times this as an argument to not do it. Even so, endoscopic vessel harvesting is absolutely state of the art in North America. Like 90% plus of all procedures are done endoscopically, while here in Europe, it's more the opposite. It's somewhere between maybe 15 and 20% endoscopically. There are studies showing that the technology is also cost efficient and superior to open vessel harvesting. So it is certainly worth trying, and we see this also is improving, and we see increasing case loads from year to year. So this concludes my short presentation. I think there are many examples where we can clearly say the MiEK idea, the MiEK concept influenced device development, but also the techniques that are used in daily practice. And I'm really looking forward to see further progress in the next coming decade. Thank you very much.
Thank you very much, Andreas. Now the next speaker will be from Livanova. It's Mr. Deriu. I'm right. Deriu. Is it?
It should be good. Yeah, I think actually you got that. I say, you do mine, I'll do the one for you.
Sorry, it's my fault. Sorry, Michael.
That's all right, man. It's all family here anyway. So, hey, just two things that are really interesting of the last two presentations. There are opportunities there for the perfusionist to be doing more than just sitting behind the pump there, right? So what Savata was talking about is something that I believe in as well. That what I'm going to be presenting on a little bit in terms of what we're doing with ECLS and long-term support. But that there is a role there for the perfusionist to continue to be involved with everything that's happening, not just in the operating theater, but also in the ICU. Be it respiratory or be it a cardiac ICU. But what was really interesting about what Andrea was showing is that there's a real opportunity for vessel harvesting and having the perfusionists participate in that. And I remember the first time I saw that Terumo technology was actually the chief perfusionist in Dresden that was doing the actual vessel harvesting. So there are plenty of opportunities and things that are being developed here that aren't just specifically surgical or perfusion, right? And that's a big part of what you're going to see a lot of us as manufacturers continue to do. How do we continue to find a role as things evolve to keep the perfusionists involved in that? So thank you both for both of those points. I think that's really valid. As I'd introduced myself yesterday, I am the Vice President of Global International Business Development for a new startup company that's called CBM Life Motion. I'm going to talk a little bit about the company, very briefly about the technology, but also just share some ideas on where we're going to be going with this specific technology. I'm also the general manager of the factory that we are building in Mirandola. which is the town that I live in. So, and we'll come to why are we building 2 factories? And I think that's an important point. The story behind the company is pretty interesting. We brought a standalone ECLS adult system, a complete ECMO system. We were able to bring it to market during COVID. The Chinese government was looking for opportunities to work with industry in China to be able to find a way to bring this technology to the market during COVID, because unfortunately, China was a country that was somewhat left out in the ability to treat patients, as many of the manufacturers in Europe and the United States really kind of focused on the customers that they had to serve in their own countries. But with what you can see here from this from the slide as well is that we did establish the facility in Mirandola. That company has already been founded, so we're going to be breaking ground on the clean room here shortly. I'm going to talk a little bit about why we're doing that. The thing that really drew me to this opportunity is it's creating something from nothing. China Bridge, the parent company, has been able to bring this technology into the Chinese market, and it's ECMO technology. So from an engineering and from a marketing perspective, for me, why this made sense is that, okay, you're talking about the most difficult country to get into in the first place. The market potential in a country like China is enormous. And then when you also factor in the fact that this is the hardest technology to develop, there are so many things that can go wrong with development of ECMO technology. From an engineering standpoint, they had the most difficult technology on the market, and they were already in the most difficult market. So for me, being able to jump into this opportunity, being able to be a part of something from ground zero, but more importantly, being able to create the culture of making this company international. The fact that they, committed to being able to build a clean room in Mirandola, just because they wanted me to join this company, says just how far they're committed and how much I'm committed to it as well. Animal laboratories, self-contained laboratories for doing biological testing. The amount of investment that this company has done already in extrusion, micro extrusion, molding, it means that from a vertical integration standpoint, the idea is to try and minimize the risk to you guys that we're not going to be able to become be a commercial partner with one of your institutions. We don't want that to get interrupted because of supply problems. And that's really the purpose for the dual manufacturing society part of this. The message here for this, for CBM Life Motion, which is the branding of the company outside of China, right? That's the part that I'm responsible for. The message here is that we are going to eat, live, and breathe ECMO for the next 5 years. That is it. That's all we're doing. We're going to be focusing on getting this product out into the U.S. market, followed soon thereafter by the market into Europe. And it's not just AV. We're looking at VV. We're looking at what are we going to need to enable this technology in ECPR? What are we going to need to be able to enable this technology to be better accepted, even for veno-veno? What kind of patient monitoring do we need to be able to really make sure that we're meeting the requirements of respiratory support and respiratory failure? But as we get into what is the technology itself, it's a self-contained complete ECMO system, right? And as Andreas had said, for the same reason, this product is only available for sale in China at the moment. And I do have to caveat this with we have made the requirement, or we have met the requirements for filing in the European Union. We've done those filings, and we have filed with the FDA already on the system. But I think when you're talking about is a system that's enabling both in-hospital and outside hospital transport. And when we talk about the completeness of the system, it is if I could take a step back, the pump design and the console, and what really lured me and really made this whole opportunity so attractive to me, it's people that I worked with when I was at Dedeco, right? So the chief engineers that designed all the disposables, if they weren't based in Aachen, which was a university hospital that we used to work with all the time, when I was at Dedeco, it's also the chief engineer and the chief manufacturing officer that are involved in this company. The equipment was designed by the guy that designed the S5 for Stockert. So for me, that meant that, okay, this is me going into familiar territory, but it also means that conveying that message about this technology being designed in Germany, but actually being built in Shenzhen in China, just outside of Hong Kong, that's kind of going to be the first step. The second step is that we will be, as of next year, we'll start manufacturing the disposables of a second generation oxygenator design that is of Italian base and by nature is going to be built in Italy. That's the product that we're going to continue to go forward with. We will be going after a 14-day indication and an ECMO indication in the United States. With the second device, it'll be a lot longer than that. But again, we filed with the FDA, and we have filed our CE mark as well. But when, Savannah touched on a very important point. From my standpoint, what's important to me is that I do not want to have to go to any of our customers and say, I'm sorry, we're not in a position to be able to supply product. The whole strategy about the way that we're structuring ourselves with MDR, the way that we are structuring ourselves as a company going forward, we're doing as much as this as we can internally. And that's the power and the beauty of having the manufacturing capacity of a country like China behind this international venture. But with the design expertise that comes from Europe, the design expertise that also comes from, specifically from Germany, what we've done is we've created a system that we're going to be able to go forward with, but with the intention of having one facility back up the other. The facility that I'm going to be responsible for is effectively only going to be supplying Europe and the United States. However, if one of the factories is not able to if one of them goes down, we've always got the second one to be able to back it up. So everything that we're doing, even from a manufacturing standpoint, is always having one system being able to back up the next. So just so that you guys have sort of an idea, and what we're doing when we're talking about this is the kind of a quote from our CEO, who she's a electronic engineer. She also worked in Germany for about 20 years with the University of Hanover and set up the reimbursement program for that hospital. So it's somebody that really does appreciate what it takes to be able to bring a product to market in Europe, but also what kind of clinical evidence is going to be required to keep that product on the market. And I just wanted to maybe share this with you guys as a first step. This is the first official presentation I've done on behalf of the company. As we go forward, this is a perfusion technology company. And yes, we're going to be focused on ECMO. Yes, we're going to be focused on being aggressively coming out with cannula that are going to be challenging the specialty market. But we're also going to be, at some point, jumping back into the perfusion piece, because there's no one that can convince me that a company developing ECMO should not also be in the perfusion space, period. And you have my commitment that that's exactly what you're going to see a lot of me in the next 10 years in this role. I'm really talking about what we're doing to advance the state of technology in perfusion. One thing I forgot to mention yesterday and I'm really, I do apologize for not having mentioned this. Professor Beaufortin was in the, he's a part of the faculty, but he was also in the audience. I don't know how much all of you are aware of just how much he really, the work that he did with Aldea in the United States, with Professor Shapira, that was in Boston at the time, went to Israel and is now back in Boston. The amount of work that that group did for biocompatible surfaces was the foundation for everything that came after that. Everything that we did with Balance, everything that Dideco or the Sorin and Eurosets did with phosphocholine, all of that work was based on the foundational work that Aldea, Shapira, and most importantly, Professor Beaufortin had done. And I did not have a chance to mention that in my speech because we just covered so much ground so quickly. But I did want to make sure I made that point before I stepped down. So thank you very much.
Thank you, Michael. That sounds really promising, and wish you all the best.
Thank you,
Now, sorry again, next speaker will be now Mr. Deriu from Livanova. Please.
Ladies and gentlemen, good afternoon. I'm Luca Deriu from Livanova, and today we have decided to talk about the Essence perfusion system. We have started this project in 2017. So we have gathered a lot of feedbacks from more than 300 perfusionists worldwide. And we have started putting everything together. So we have discussed directly with the users every details of the machine, from the smallest one to the most significant. And at the end, in March 2023, we have delivered a system that is able to bring you what you see in this slide. So safety and reliability, patient-tailored care, intuitiveness, and flexibility and efficiency. Now, my goal today is to go discuss with you briefly each of these pillars, and also to provide you some information about the first milestone that we have achieved so far. So now, when we talk about safety and reliability, so we are Livanova, so we are market leader in the heart-lung machine. So, and we have to take into consideration that if you enter in a random cardiac surgery in Europe, in more than 8 cases out of 10, you will find an S5 running a perfusion. So it is not easy to improve a so successful device like the S5. But our goal is not to negotiate with safety and reliability, because S5 is the state of the art of safety and reliability. And for this reason, we do not negotiate with safety and reliability, and we have decided to keep some of few features that are included in the S5. For example, the direct drive technology that is really efficient. But on top of that, in order to improve, to go also more in the safety things, we have also added several safety precautions. So, for example, some redundancies like the backup control panel, or, for example, the possibility to plug additional, in case of need, additional pumps. Or also, for example, an important point is the concept of one knob for a single pump. And finally, on top of that, also our service support that is well known. So probably you know better than me our service technicians that are able to reach you in few hours sometimes. And we have a really important network of service in more than 100 countries worldwide. And then let's talk about the patient-tailored. So now this is a combination of several points. So the first one is the accurate sensing technology. So let's talk about the sensor. So from the flow sensor, bubble sensor, but also the inline blood monitor sensor. And on top of that, you will have the possibility to use the official formulas of the GDP in order to properly monitor the metabolic needs of your patient in real time. And also another important point is the possibility to have the mass-mounted pumps. So in comparison with the S5, Essence give you the possibility to place the pumps along the MAC system based on your clinical need, providing also some kind of flexibility, and also for you that you are doing minimal invasive, also for reducing even more the length of the tubing systems. Talking about intuitiveness, there are several points that are really important here. So we have decided to provide something that is intuitive and able to provide you the possibility to do complex things in a simple way. This is an important point in my opinion. So the user interface is intuitive. The machine is easy to, so the learning curve is short, and give you also the possibility to record and continuously the data from, for example, for the Essence patient monitor. Another important point is also the possibility to improve the platform. So this is a technology platform that is really open to be improved also for example, automations or algorithms. Now, the last point is related to the flexibility and efficiency. This is important as well, because we want to provide you a system that is able to fit your clinical needs. This is important, your clinical needs, but also infrastructure need, like, for example, the OR footprint. And so for this reason, we give you a system that is really versatile. And also in terms of ergonomics, we have provided some additional feature that will give you also from a conceptual standpoint. For example, just things to the cockpit that provide all the relevant information you need to take into consideration during the perfusion in a smaller area in comparison with the S5. So placing the cockpit closer to the disposable give you the possibility to maintain everything under control in a limited amount of space. And also the possibility to integrate with the external devices or through DHL7 connectivity to the hospital information system. Now, having said that, I would like just to go briefly and to show you where we are in terms of commercial achievement that we have just gathered. So I would like just to mention, for example, also because we would like to run with you the short history that we had with this perfusion system. So now you can see in this map that now the machine is widely used worldwide. So you can see in all the continents. But what I would like to underline are some of the first cases that has been done. The first one is important for me to mention, has been performed at the end of 2022 by the team of the Catarina Hospital. And this has been a really important milestone for the company because we had the possibility to start with the clinical trial of the machine. And after that, in fact, we have limited the use of the machine in some hospitals in Europe and in the US. But after that, we received the FDA clearance in March 2023. And as you can see, for example, in this case, the Franciscan Health in Indianapolis did the first case in US in April 2023. But you can see also in Australia, in Dubai. And I would like just to finish mentioning the first in a hybrid MiECTiS environment in Coswick in September 2023. Now, this brings me almost at the end of this presentation. So up to date, starting from March 2023, we are celebrating 1 year of success of Essence perfusion system. So as you can see, the machine is already present in more than 20 countries. More than 190 systems has been sold so far. But what is important is that already thousands of patients benefited of this from this technology. So talking about pediatrics or adult surgery, but also minimally invasive. So this really brings me at the end of this presentation. I would like just to mention another really important point. So we are market leader in the cardiopulmonary arena. So our goal is not just to deliver a product on the market. Our goal is to provide the best system possible to you. And for this reason, in order to achieve this goal, this is just a journey that we are starting. And we are starting together with you, with the perfusionist community, because we need the feedbacks from the users. That is a really important point, especially because we use the user-centric design that is really put the user in the center of the process. And also because we have several commitments. For example, one of the commitments is to release at least 2 firmware software version for year, 2 for the machine and 2 for the Essence perfusion system. But what is important to underline is that inside those firmware update, there are the feedbacks that we received from the users. And this is important because we have a really structured way to gather your feedbacks and to include in the next software releases. This is an important point because at the end, the machine will reflect which are your real needs. And in our opinion, in one of the most important points. So having said that, I hope that you will participate to this journey together with us. Thank you very much for your time.
Thank you very much for this nice presentation. Our next speaker will be on hold. It will be Mr. Fangarecki from Euroset. Ettore, please.
I'm hoping that you see me. Hi, my name is Ettore Fangareggi, a member of the cardiopulmonary marketing line inside the Eurosets. And I'm here to present you the Lang Advance, our new complete, intuitive, and versatile solution to monitoring CPV and ECMO treatments.
There are contexts in which every single moment is important. And it's exactly here that technology comes into play to help and support us during clinical practices. And when the journey comes to an end, we get how much every single step has been essential for a flawless landing.
So, as I said, these are the main claims for our new monitoring system, and we describe the Lang Advance as a complete, intuitive, and versatile solution. So complete because with just one monitoring system, with just one device, we are able to have a full overview of your procedures, both in ECMO and CBB, not needing other external devices or accessories. In CBB, it is really, really useful because it provides you all the information regards the goal-directed perfusion that is almost a must to be used nowadays during clinical practice. And also talking about the ECMO procedures, it's really useful because of the information regards the performances of the oxygenator and also how the patient it is recovering from the treatment. It is an intuitive product because it has all the graphic user interface that is based on how the users can customize it, based also on users' needs. And at the same time, it's really easy to read it and to understand the information that the product is achieving thanks to the enlarged screen and upgraded accessories. It is a versatile solution because it can be attached to any ECMO or PTS, but also it is suitable to any HLM device, meaning that even in particular scenarios like in the minimal invasive extracorporeal circulation, you can have just one device with all the accessories related that can be attached to your circuit based on your need, and you're still able to use it in every procedure that you want. It is a complete product because in CPB treatment, we have 22 different parameters measured or calculated that provides you all the information regards the status of your treatment, of your procedure, so the oxygenator and your circuit, but also everything related to the metabolism of the patient, meaning that with these 22 parameters, you are able to achieve a 100% and a 36 degrees goal-directed perfusion during the procedures. Talking about the ECMO treatment, we have 18 different parameters still calculated and measured with non-invasive technology. And these parameters are really useful to understand the trend in terms of recovering of the patient and to understand if there is a possibility to start thinking about the weaning of the patient or not. These are the two main graphic user interface area with all the parameters listed above and the graphics in the middle page, and also all the settings and data management system on the right. It is an intuitive product. Why? Because everything can be personalized in this monitoring system, starting from the graphic user interface, where you can move all the modules inside of the screen based on you want it to be based on your practice, and also you can customize all the alarms related to the parameter listed by the monitoring system. The probes are really, really easy to use it because you just need to plug it on the monitoring system and then on the circuit, thanks to the non-invasive technology. And at the same time, it provides all the information in real time, not needing so to wait for other information to be listed. Also, it is really easy to read, thanks to, as I said, to the new graphic user interface area, where you have a large space for the graphics that are really, really useful to understand if there are problems or how some parameters are changing during the time. Here you can have up to 8 different parameters listed in real time. And also in this page, you can personalize everything, for example, the colors and the position based on the preference of you or your colleagues. And also, last thing that we claim to be an intuitive feature is the data management system. Inside of the Landing Advanced, there's an electronic folder, a complete customizable electronic folder of the patient, where you can list all the information that you want to record about the treatment, the surgery, the procedure, and all the information that you are thinking about, in order to have a complete record, a complete folder of your cardiopulmonary bypass treatment to attach to the patient folder or the hospital network. It is a versatile solution, as I said, because there are no limits in terms of how you can use it in heart-lung machine devices. And also, it is really, really easy to set up based on your preference because of its lightweight and the dimensions. And there are no limits also on the ECMO side, thanks to still the non-invasive technology, not needing so to change the circuit or to apply some modification to it. So also, talking about the PTS, there will be available also Wi-Fi probes that are really, really useful in order to improve the cable management in your heart-lung machine, your circuit. That is still something that perfusionists are struggling with. And not having any issues to use this product with any PTS, even in minimal invasive extracorporeal circulation, we are able to use at 130 degrees one monitoring system, providing you all the information and all the technical characteristics that I listed you before, not needing so to have a specific device different from the CPB, the standard CPB configuration. Yeah, to sum up, these are the main new feature compared to the landing, the previous version of the landing. And these are also the claims that we achieved to have it more reliable and also more intuitive, more complete, and more versatile. Thank you so much.
Thank you very much, Ettore. I think we are just in time, and I think we can close the session. Do you have something to add, John? Or?
Well, I would just like to say that as someone who's been involved in cardiac surgery for a number of decades now, it's remarkable to me the interaction between clinicians and industry. And I think what we've heard today really reflects that. I actually go back to the days of bubble oxygenators. I was here with the when all of the initial work showing the inflammatory response and the response from industry is to develop biocompatible surfaces. We're concerned about blood transfusions. Once upon a time, we used to prime the pump with blood. The recognition years ago that this is adverse has led to industry to miniaturize these circuits. So I think this really does reflect this very productive alliance between clinicians, industry, and our overall concern with optimizing patient outcomes, reducing costs of care. And I think this is really a very productive collaboration. And we look forward to further developments in this area. So thank you all very much. I think this is very productive.
Just a question here.
We have a question from the floor. Sorry, please.
First of all, I'd like to thank you for this compact and precise presentation. I have a question. Where the industry market stands for using MiECT in the pediatric population, is there any available data we have? This is, so I was curious because these 2 days have been great. It was a very nice meeting. And didn't hear anything about children. Do you have an orientation in the industry for using MiECT in pediatric population? I think everyone is speechless.
Well, I can tell you definitely yes.
Yes.
Yeah, so look, you're actually, it's a fair question. I've worked with Hans-Jörg quite a bit on trying to find solutions for a MiECT solution to pediatrics. And it's complicated because of the amount of air, right? It's the amount of surface that's actually open, the amount of intervention that's required for most of the congenital procedures. And I think it speaks to the need to really find ways to be able to further eliminate the blood-air interface. And quite frankly, one of the challenges industry has is that the pediatric market requires very specific dedicated devices, but it's a very small market. And in many ways, even when I was at Dedeco, the difficulty was finding the funding to be able to continue to develop, even though these are the patients that need it the most. Really being able to develop products in that market, it's really, really difficult. And it's even more difficult now because of the regulations to keep those products on the market. But there is someone here that has done mini bypass with pediatrics. So maybe he can talk about it a little bit.
Yes, we did some cases with mini bypass, but I can tell you it's quite challenging, and the technique was not so far. And also in respect to the numbers we had, we were not able to give some recommendation about pediatrics. Pediatrics is the same, but I think your question was also a different question, because we come not further in development in pediatrics because there's no money. And we see that, for example, for LVAD, we still work with Berlin Heart. Berlin Heart, that didn't change the ventricle since 25 years or 30 years, yeah? That's the problem. We struggle with that a bit. And I think I'm really happy that Sevada announced a new pediatric cannula for FVV ECMO, yeah?
Okay, thank you.
Yeah.
I woke up at 3 o'clock.
Okay. So hello, we come to a new session. This time we're going to talk about the ERAS and probably try to discuss MiECTiS with ERAS. So today we have a very good expert group, mainly from US. There's ERAS Cardiac Society, and those are the executive members of the society that are going to give us more information about this and combination possibilities. So the first talk will be given by Michael Grant, who is an anesthesiologist in US and also a member of the executive board. Hi, Mike, how are you?
I'm doing really well. Thank you for having me today.
Thank you very much. It's our pleasure. So Mike will be talking about the latest consensus report that was published by the ERAS Cardiac Society. Yes, please.
Right.
Thank you.
Great. Sure. I'm going to share my slides here. Okay. So thanks again very much for the opportunity to speak here today. I'm going to give you some highlights on our new ERAS cardiac consensus statement. Okay. So with respect to this, I have no disclosures. So I'm going to start by just basically pointing out that this group, the Enhanced Recovery After Cardiac Society, along with the ERAS International Society and the Society of Thoracic Surgeons, put together recently an overarching perioperative care and cardiac surgery joint consensus statement. It's a big document, but we wanted to have a nice forum here to be able to discuss some of the specifics about that document. I'll start by talking a little bit about the background and the rationale for why we even did this effort in the first place. I'll then talk a little more about some societal collaboration that extended from this. I'll give you a little bit of a document overview. I'll give you some general take-home points, and then we'll talk a little bit about the future directions and areas that we could not talk in depth about in the document itself. So I think it's first important to explain a little bit about why we did this effort. So just as a bit of background, standard care brings a patient into the operating room with a certain degree of overall baseline recovery. We insult them significantly with a major surgical insult, and standard of care, unfortunately, only gets them back to somewhat just below their original baseline more often than not. Enhanced recovery purports that we can heighten that baseline, optimize them ahead of surgery, lessen the surgical insult, enhance their recovery, hence the name, and then send them out at a better baseline than whence they came. It turns out that this enhanced recovery concept has become very, very popular in the literature. If you look at just broad swath of PubMed articles that look at just enhanced recovery alone and then enhanced recovery for cardiac surgery, you'll see that there is a burgeoning interest in this topic. And what that means is that there is an overwhelming amount of literature. The basic background of any individual topic that might be incorporated into perioperative care has exploded. I'll give you an example. If you were to look specifically at postoperative nausea and vomiting, just one component that's housed within our document, you'll see that there are at least 4 separate iterations of those guidelines. And since 2020 alone, there have been more than 7,000 articles published. This has an untenable number of agents. There are a number of different outcomes that are reviewed, a number of different side effects. And if you look at the network analysis, there are a million different interactions that you could have between these specific agents. And as a result of just the volume of those data, what we decided as a group is we would consolidate them all, at least in a point in time, and help the bedside clinician in a distilled format to understand best practices about how to manage patients on an individual topic basis. These are the authors. You'll note a number of people from across both the domestic United States, Northern America, Canada. We have a number of Europeans listed here and a representative from South America. This is one of the more international efforts that you'll see that is embodied in this. I want to also say that we had a strong collaboration point with the STS and the International ERAS Society. We are a sister organization to the International ERAS Society, and I'll call out some of the individuals within the STS who saw the vision for this particular document, and they're listed here on the right-hand side. We started with an initial meeting in 2021 where we identified our consensus group and listed the various elements that we thought should be included in that document. That we then underwent a scoping review of the literature. So we looked at as much of the literature as we possibly could from its inception until present day, mindful of the fact that the data that we incorporated into this document needed to be representative of daily practice in modern America and modern international sceneries. We did a literature assessment that consolidated all of the relevant texts and summarized the literature, and then we assessed the quality of that literature. We then prepared the document, and then it underwent formal review and endorsement from all three individual societies. And again, this effort took us roughly 2 years to complete. The document is housed within what I affectionately call knowledge chunks, but basically the idea is that we introduce a specific topic. Here is our subsection on pulmonary artery catheters. We give you not only a little bit of background on that particular topic and what the literature essentially says in that area, but we give you a summary statement, an overarching statement of what we believe to be true about that topic, and then the quality of the evidence. And this is derived across roughly 24 different elements in the document, and those elements are listed here. We divide this document between the general principles. These are things like shared decision-making and patient engagement. We then divide it into pre, intra, and post-operative settings. And then, as you all know who are clinicians at the bedside, a number of these elements just simply cannot be incorporated exclusively into a single phase of care. And so we have a number of multi-phasic individual elements as well. And we go through each one of these and the literature associated with it and provide a take-home message for each one. So those take-home messages are then incorporated into a table. You'll see roughly 24 of these listed, itemized as shown here. Statements are consolidated. I haven't listed all of them here just for the sake of the space of this particular slide, but we give you the level of evidence associated with it. So it's a readily take-homeable. You can print this out, use it at the bedside for your own benefit. But what we've taken great care to do is to create bundles of care. This is a great example of the preoperative risk assessment bundle. The idea here is that there are a host of different elements that you can capture about your patient that can identify their risk threshold ahead of surgery, allow you as a patient, allow you as a clinician to inform your patients of their impending surgery and then the risk associated with that, but also then take the steps that are necessary to have the resources at the bedside to care for those patients. And you'll see them listed here. For the sake of time, we won't go into each of the specifics, but they don't only incorporate things like Euroscore or STS predicted risk of mortality, but a host of different elements that are not necessarily commonplace. Frailty assessment is something that is now more recently being incorporated in earnest. We believe that's something that should be done for every patient. And then there are a number of other elements here that are laboratory, but I think one of the more novel aspects of this is that we recommend that people obtain sleep apnea screening and look for opioid tolerance. We touch on atrial fibrillation prevention, surgical site infection prevention. We've gone to great lengths here to identify the bundled elements that have been shown to reduce the incidence of both of these outcomes. They're itemized here. We have a subsection here devoted to each one of them as well. Patient blood management is a central theme within the document. There are a number of elements here, multi-pronged. They incorporate the three major tenets of patient blood management, that is preoperative anemia optimization, minimization of intraoperative and perioperative blood loss and hemodilution, and then permissive anemia in the postoperative phase. For the first time ever in the cardiac arena, we have also taken great care to talk about nausea and vomiting and its prevention after surgery. This is something that has been long underappreciated in cardiac surgery and something that we felt very strongly needed to be incorporated more obviously in this document. But the document is not entirely complete. We believe it is the first iteration of several to come. The reason for that is because there are a number of elements that we just simply can't make an overarching statement about, basically because of the nature of the existing literature. Some of those include, and this is important for this particular topic area and this particular conference, minimally invasive surgery. Although we'd love to make an overarching statement about minimally invasive surgery, we feel that there's still a lot of work to be done here before it can make its way necessarily into a consensus document of this type. We looked again at drain management and felt, again, this requires a little bit more work, both in the cardiac surgical space for blood retention, but also in drainage of the pleural space as well. And then, of course, mechanical circulatory support. This is an area that is of significant interest, not just to this audience, but to cardiac surgery writ large. And the number of high-risk procedures undergoing is growing and growing and growing over time. And so eventually we hope to incorporate mechanical circulatory support and a specific statement about that particular paradigm in our next document. So with that, I will just conclude by simply saying that this has been published here. It was out in press in January, and it is now in print in April. Here is a code here. The QR code will take you directly to this document. It is open access, by the way, so please feel free to go and take a look at this document, download it in earnest, use it for your teams. And if you have any questions, please feel free to reach out to me. This is my email, mgrant17@jhmi.edu. I love to get emails from anybody, anywhere, anytime. Happy to answer more questions as they become available. So thanks very much. I'm looking forward to the discussion.
Thank you very much, Mike. So I'm here with expert intensivist from Greece, Dr. Nalbanti, and John Merkin from Canada, anesthesiologist. Maybe they have some comments or questions for you.
Good evening, and thank you for your excellent presentation. I think that last years, the ERAS protocols are the state of the art, as it consists from, they are consist from every topic about pre-operative phase, operative and post-operative. As an intensivist, we will look forward to follow all these guidelines, but as you understand, and I think it is difficult for all of us to change what we already done and to be in a new era where we have a multidisciplinary team to cooperate, coordinate, and work all together to make the best outcome for the patient. I think that this is the most challenging from the ERAS protocols.
Yeah, so I think it's a good point. We could probably talk about the evidence all day long, and a big part of this consensus document and the reason that we put it together was because just the first step of consolidating that evidence on an individual basis is virtually impossible. But you're right. The real key to getting this done is the implementation element of it. How do you take all of that, translate it to the bedside, and manage change with your team? And we have done a lot of work in our society in this area as well. I will offer that everybody who is interested to go to erascardiac.org. This will give you an opportunity to download a number of our implementation outlines. It gives you a lot of insights on how to go directly to your team and incorporate them into that change. The other thing that we've done, and you can have access through this website as well, is we have created turnkey order sets that allow us to take our guidelines and these individual bundles and actually translate them directly into orders that can be readily utilized at the bedside. So we've tried to do some of this work, but your point is very well made. We need more research in how to implement this specifically. That is, how do we improve the quality and safety of patients by taking all of these data and actually translating it to clinical care? And we look forward to partnering with anybody who's interested in helping us to do that.
Thank you. And John, will you like us?
Well, again, I think, as you're aware, this is actually a very important document because it really does bring together in one place issues that a number of us have struggled with over the years, and including the fact, for example, as you say, encouraging the use of a more restrictive transfusion strategy. Permissive anemia, I think, was the term you've employed. Because that's one of the confounds when one strives in the operating room to minimize transfusion and then finds that post-operatively, for whatever reason, the patient is being transfused based on more on numbers rather than the patient's performance. So I think the ability to sort of in one place say that if we're doing an ERAS program, it allows one to really try to help educate other members of the team looking after patients as to some of these more innovative practices. So I think it's a very important document. So thanks very much.
Well, I appreciate that, and I'll call out Ron Salinger, who's going to give a presentation here shortly. And this is something he believes very strongly in, is patient blood management. He'll speak more on this. I think one of the things that comes up a lot is people use the term transfusion trigger, meaning if you drop below a certain threshold, you are quote unquote obligated to transfuse. And we are pushing back on that notion. The idea is that we should really be using physiologic data that would support the decision to transfuse, as opposed to the trigger term that basically suggests you should be automatically doing it. And again, I don't want to steal Ron's thunder, but that's a concept we believe very strongly in.
Mm-hmm. Thank you. And I also will ask to the other speakers. So I know regarding the name of this society, so I know minimally invasive extracorporeal circuits are not very much in fashion in the US, but how do you say the impact of such circuits for the ERAS protocols?
Well, I mean, I think one of the inherent benefits, of course, is that you're going to have much less hemodilution. You're going to allow those patients to have much lower likelihood of transfusion. I mean, what we know, and this is something that I'm sure is a hallmark of what you guys have talked about in these 2 days, is that any transfusion is associated with a greater risk of mortality after surgery, not to mention the number of organ injuries that accompany it. So the interplay between the enhanced recovery concept and goal-directed perfusion of all kinds is very clear. And to the extent that we can leverage goal-directed perfusion as this very cardinal moment in the insult within the intraoperative and in some cases post-operative settings, the more that we can leverage that interaction, the better those patients will do. So we're a firm believer that this is a core tenet of the enhanced recovery concept.
Thank you very much, Mike. Thank you for this great presentation.
Thank you.
Now I'm going to continue with the multidisciplinary team and implementation, nearly the first step to start with the ERAS protocols. So as you know, according to the numbers of WHO, the complication rate in whole operations is about 25%. It's high. And the death rate is 1/20. So it's, again, not a very small number. And usually half of those reasons are adverse events based on surgical reasons. And the most important point out that is half is preventable. So that's why the healthcare systems are in a kind of evolution. So we used to work on volume-based type of surgery. We were crazy doing more and more operations. Okay, so if the patient doesn't die, then there's no problem, we were thinking. But now the system is improving on the patient-tailored and value-based models. So this is I think, the next step and then the idea of the future of the surgery. So the first step we need to reach is the form of a multidisciplinary team approach. And it's not easy because if you want to start an ERAS program, it covers a list of participants, starting from nurses, surgeons, anesthesiology, intensivists, and so on. So everybody should work cohesively and understand the culture and should be motivated to apply those kind of process to increase the success rate. So as Mike said, in the ERAS Cardiac homepage, you can find any type of turnkeys or information about the implementation process. So basically, since we need to try to use these value-based concepts into our clinical practice and to keep on and just reaching on this quality improvement and work with the heart team. So this team is a large team, not easy to work together, but this is the base of the success. So basically we are using patient-specific protocols and within the multidisciplinary team approach. So this was the paper published again with the ERAS Cardiac Society about the 10 commandments of ERAS for cardiac surgery. And number one is to create a cohesive and multidisciplinary team. So, and then Mike just mentioned all about the new consensus report. And in this report, the program implementation and sustainment is cited as a moderate important point to include in the ERAS. As I've told you, you can find those documents in the ERAS Cardiac Society homepage. So to start with the ERAS Cardiac team, the idea is to find a kind of program coordinator. So this is the most important step. And so then you should all come together to agree on the interventions. And of course, these all should be applied to your own current practices and opportunities. So this is the most important point. For example, when we start the program in our clinic, we translated the guidelines from English to Turkish, but that was not enough. So we also adapted those ideas into Turkish lifestyle. And then you have to utilize the database. So always you need to talk with data to increase the power to impact over your practice. And of course, should everyone come together to discuss the barriers and how to overcome them and to find people who can solve those kind of problems. So because there will be many problems related to patient or related to staff and even related to your own practice inside the hospital. So the timeline can be different from one center to another. For example, in our center, we had a very long experience of the patient management program that was built up like 6 years ago. So it was comparatively easier for us to start the ERAS program. But of course, you can just fix a kind of timeline for you and try to just go on within this timeline procedure. So ERAS is mainly a concept, especially in cardiac surgery, is a multi-model. We are always saying this, but of course, they are not easy to come together and do all of this teamwork, like multi-model, transdisciplinary initiative and promote the recovery. So you have to make easier the patient journey starting before surgery and going home and even after being discharged. So we started the protocol at the end of 2020 in our hospital, and we now did about more than 1,000 cases. So it's a large hospital. So the idea was to start founding a kind of team. So we organized a consensus meeting and invited all people, all participants in the ERAS community and discuss how can we start this program, what are the barriers, what can we do, who needs to be the program leader or so. And then we started educational programs with the selected group. Even national and international educators come to teach us and to organize the group. And then we formed a large team because it's a large hospital with 4,000 beds, 12 operating rooms in cardiac, and then protocol. So it was difficult, as I've told you. We translated the protocols, we modified them. We just visited every participant's clinic to understand what are the barriers, and this is the final protocol that we started. So ERAS guideline that was published in 2019 offers 22 recommendations, and we nearly tried to cover all of them. So this is the video, brief video, what we have done or what are we doing now. So as I've told you, We work in one of the largest hospitals in the area. It was newly built in 2019. We have around 4,000 beds, 750 ICU beds. There's 6 towers, each was focused on something else. The one tower is in cardiac. So we have very new technology equipment and beds and wards. So this is the prehabilitation program. So when the patient is decided to have a surgery, comes to our fellow, he describes everything, signs the paper, gives information, sends to the dietitian. So dietitian sees the patient, do all kind of measurements and biochemistry to understand the nutrition status of the patients before surgery. And 15% of our patients are already malnourished before surgery. So she helps them, gives some additional products, and then if she has or he has anemia, we treat them with iron before being in the hospital. And then patient comes back to the hospital, again, some paperwork, additional information, and dietitian does a ward round twice every day. And then before surgery, we do carbohydrate loading to deal with the insulin resistance. Neurocognitive evaluation is always evaluated by the anesthesiologist. So this is the operative protocol. Before surgery, as I've told you, especially if you're doing minimally invasive surgery, it's incredibly painful. So we routinely do blocks before surgery. If the sternotomy will be done, then the first thing to do is the erector spina block. Of course, this took a lot of time to establish this protocol in a routine case. And then if the saphenous vein will be harvested, then saphenous block will be done. So this really goes on a long 5 to 6 hours that it's helpful for us. And of course, monitorization is very important in these patients, as just already mentioned. Goal-directed fluid treatment, goal-directed perfusion, and if there is a bleeding, goal-directed coagulation is important. If we are doing minimally invasive surgery, again, the pain is important, so we always put a catheter before sending the patient to the ICU. And in the operating room, we use whatever we have, like hemodulation, endoscopic vein harvesting, MiECTiS, of course, and autotransfusion. And this is the minimally invasive techniques we are doing. And again, bleeding is important, so we use some topical hemostatic agents with some specific applicators within the small incisions. And of course, we try to use every additional technique to decrease the cross-clamp time, CPB time. I'll use some sutureless valves, some different incisions for valve surgery. And ICU is another important place, especially physiotherapy is very important. So we have dedicated physiotherapists for the patients. And of course, neurocognitive follow-up is always very important in the long term. And then we follow up those patients at home. So we started using this remote monitorization. It's a new device. So you can monitor even how many steps the patient has taken inside his home. So they can send us SMS message anytime they like to ask something. I have this symptom or I have this problem. So, and the results are very much promising. In the early results, as I've told you, we didn't know anything before about nutrition before this type of protocol. And we documented that 15% of patients are already in malnutrition when they come to us. And during the perioperative period, we needed to do for 45% of patients some additional nutritional support. So this was a new concept for us. So for the implementation, as I've told you, we have a teamwork experience with PBM that's helped us very much. We have experience in minimally invasive surgery and MiECTiS helped us very much. We have some previous reports and research about delirium that really helped us. And of course, we have some, again, some techniques for the infectious pickup and help us sternal closure. And for the challenges, we did know nothing about nutrition. And so we really had a lot of training, we learned many things about nutrition. Non-opioid anesthesia, we knew nothing about it when we started this program. And physiotherapy was not that much important for us before starting this program. So with the transition, we need to come to the value-based models, patient-tailored models with the really multidisciplinary team approach. These are all very difficult concepts. When they come together, we always have a success. So minimally invasive ACC is one of the most important hallmarks of this program. And again, ERAS, I believe, will be the future way of handling patients. So as being in Greece, so I'm going to talk about the handmaids of Aphrodite. And she has three maids. One is Joy, the other is Splendor, and the third one is Bloom. So each one of them should be included in the ERAS protocols. Thank you.
Thanks very much, Serdar. I think that I was very intrigued by the identification that 15% of your patients are malnourished preoperatively. And that certainly has been an observation that we've made independently looking at individual patients. But again, this is a real opportunity to try to identify. And I think the involvement of the dietitian, not only in the preoperative assessment, but ongoing, will help change lifestyle in the long term to ensure that the patient has a very active and successful recovery. It's very successful. That's very good watching this come into practice.
Thank you. Thank you very much.
Thank you. Yeah. Professor, you mentioned about the chief of the group. This is very important in order to cooperate all the team. In our practice, we are not follow exactly. We do not follow all the parameters exactly, strictly. We screen them. We are looking about hemoglobin or albumin before surgery, and all the other parameters are each one separately.
Mm-hmm.
We do not implement all the protocols now, and this is something challenging for us.
Yeah, it's probably the most important part, but the most challenging part, as you say, of course. Thank you.
Thank you.
So we go on with Ron Selinger. Again, he's a cardiac surgeon in the US, and he has good experience in minimally invasive cardiac surgery. And he has some kind of experience, I believe, on MiECTiS systems. And he's going to give us talk on intraoperative. Hi, Ron. How are you?
Hi, Serdar. Thank you for inviting me.
Thank you for just coming here to give your experience on goal-directed perfusion. Thank you.
Yeah, I'm excited to participate. I'm disappointed I can't be there in person in Greece. It would be very nice. I think ever since Dr. Gibbon first used cardiopulmonary bypass to fix an ASD in 1953, we've been trying to figure out the best way to manage our patients while they're on this black box. And I think it's societies like yours and conferences like these that help advance our field and help us figure out the best way to take care of our patients in the operating room. I'm going to talk mainly about goal-directed perfusion. I'm going to do my best to give it some justice in 10 minutes. Mainly that's going to focus on DO2 or oxygen delivery. I do believe that DO2 is important. I think there's a lot of data that shows it's important, but I believe that it's not the only variable that's important. And I think we don't fully understand where it fits for our patients on pump. I'm going to try to convince you that pump flow is the major lever that should be adjusted to improve oxygen delivery on pump. I'm further going to try to touch on the point that I don't think we should be transfusing patients to treat anemia or to solve low DO2, mainly because of the side effects of transfusing a patient are exactly what we're trying to avoid by improving oxygen delivery. And I'm going to try to touch on the fact that perfusion pressure, as we all know, is a very important aspect of end organ tissue oxygenation on pump. Back in 1964, Jack Crowell published this paper, which showed that inadequate oxygen delivery increased mortality for patients in shock. And in fact, as far back as the 1930s, people were publishing bench work showing that an oxygen supply-demand mismatch created end organ tissue ischemia and had adverse effects. More recently in cardiac surgery, there's been a number of good studies, and we don't have time to go through all of them, but I picked a few to try to highlight. One of the best, I believe, is Marco Ranucci's randomized trial looking at goal-directed perfusion and showing increased acute kidney injury for patients who did not have adequate oxygen delivery on pump. There were a number of experts in the field involved in this study, including Robert Baker and Richard Newland and others. This is a very good study. Another randomized trial published last year from the Tokyo group also showed an association with inadequate oxygen delivery and acute kidney injury. And then this paper from the University of Pennsylvania and Trent Magruder is not a randomized trial, but is an analysis of over 800 patients where they stratified their outcomes in acute kidney injury as well as other postoperative complications by oxygen delivery, hematocrit, nadir hematocrit on bypass, mean arterial pressure on bypass, and pump flow. And they tried to look at which variables were most important. What were the results of these trials? First of all, these three trials all targeted a threshold DO2 of 280 to 300 milliliters per minute per meter squared. And in general, in the literature, that's where people have landed. There is some variation on that. So we haven't settled on the exact DO2 threshold that's important, but there's a general consensus. All three of these studies showed increased AKI when you had inadequate oxygen delivery or dropped below 280. However, they all, and most of the studies in the literature have showed that, although they haven't all shown that there's an association with AKI. And the association is almost exclusively with stage 1 AKI. That's not true for every study. It's true for these three studies and for most studies. And in fact, even when you dig deeper into these trials, there's a little bit of weakness in the relationship between DO2 and AKI. For example, in the Tokyo randomized trial, there was an association in the raw data, but if you do a multivariable analysis on their data, DO2 is no longer an independent predictor of AKI. In fact, the only predictor is pump time. And if you look at Magruder's trial, there was actually no association with AKI in the overall population of 834 patients. But if you took out all the isolated CABGs and just looked at the non-isolated CABG patients, then there was an association with increased AKI and inadequate oxygen delivery. Magruder's trial also looked at other postoperative complications and interestingly showed an association between inadequate oxygen delivery on pump and prolonged ventilation postoperatively, which in the States is defined as more than 24 hours of mechanical ventilation. They showed no difference in mortality or other complications in any of these trials. And that's true for almost all of the trials on DO2. This is another excellent study on DO2. This is from Richard Newland and the Perfusion Down Under group. This is a real world registry, which is always extremely valuable, 19,000 patients. And they were looking, they developed a predictive model for AKI and they looked at threshold DO2. And they settled on 270 as the threshold. And the way they did this was they plotted out their raw data and they tried to optimize sensitivity and specificity, and that landed at about 270. Interestingly, if you look at the sensitivity and specificity at 270, it's still really only modest if you're using DO2 only as the predictor of AKI. And the other thing before I move on, in this trial, if you look in table 2, where they did their multivariable analysis of what independently predicted AKI, there were a number of other variables. DO2 was a predictor, but so were a number of other variables that we're all familiar with: age, comorbidities, heart failure, redo surgery, emergency surgery, non-isolated CABG. So there's more to the story, this seems to suggest, than just oxygen delivery. Time on pump was also an independent predictor in this study. These are our data at University of Maryland, St. Joe's, looking at 1,000 patients and stratifying outcomes by oxygen delivery. We looked at a DO2 under 280. The yellow bar are patients that had more than one DO2 less than 280 while they were on pump. And when we did a multivariable analysis, the only thing that correlated as an independent association with DO2 was prolonged ventilation, which is similar to Magruder's trial. We found renal failure and AKI correlated in our univariable analysis, but it fell out as an independent predictor. We also found that our patients with low DO2 tended to be higher risk patients with more comorbidities. We also had a high proportion of patients with isolated CABG in our cohort. So very similar results, I think, to the Magruder and the Penn group analysis. And this study is in press, will be available shortly. If you dig a little deeper into the Magruder trial, which I think is a very interesting analysis because they looked at oxygen delivery, flow on pump, hematocrit, and mean arterial pressure, and they tried to tease out the independent association of each variable. And what they concluded was that the trends in their data suggest that low flow on cardiopulmonary bypass appears to drive the adverse effects of low oxygen delivery, as well as possibly hypotension. So in their study, flow correlated very well with the significant outcomes once they took isolated CABGs out of their population. But they also found that mean arterial pressure correlated very well with complications. In fact, mean arterial pressure dropping below their threshold was correlated with mortality in the study. But they did not find that anemia correlated with outcomes. And this actually agrees with Ranucci, who in his 2005 study looked specifically at nadir hematocrit on bypass, as well as oxygen delivery. And he found very specifically, what he found was that nadir hematocrit on bypass did correlate with acute kidney injury. But if he corrected those data for the patients that got transfused, then nadir hematocrit no longer predicted acute kidney injury, meaning that it was really the patients getting transfused that had the acute kidney injury, not the overall anemic population. And then he looked at how oxygen delivery correlated with anemia as far as acute kidney injury. So, and I think this is very instructive for people that are managing patients on pump and want to avoid acute kidney injury. If you look at these bars, so on the horizontal axis, there's 4 groups. And on the y-axis, you have your incidence of acute kidney. Actually, this was acute renal failure he was looking at. So in this study in 2005, he looked at acute renal failure requiring dialysis post-op. So this was one of the few studies that was looking at actual hemodialysis as an outcome. And the first 2 groups, the kind of 2 lighter bars, are both groups that had high oxygen delivery. So they kept their DO2s over 280. The 2 black bars had DO2s less than 280 on pump. And then for each of those 2 groups, there's a high hematocrit group on the left and then the low hematocrit group on the right. And what you see, first of all, is if you have a low hematocrit, but you're able to maintain a high oxygen delivery, then there's no statistically significant difference in acute renal failure. So that means that if you have an anemic patient on pump and you're able to turn up your pump flows to maintain a DO2 of 280, you will not have a statistically significant difference in renal failure from a patient that does not have a low hematocrit. On the other hand, if you have a patient with a high hematocrit, but a low oxygen delivery, so inadequate pump flow, you will have a statistically significantly increased chance of requiring dialysis after surgery. And then this also shows that low flow is exacerbated by having a low hematocrit, because then your DO2 is even lower. But this graph suggests that it's pump flow that we should be using to adjust oxygen delivery and try to optimize oxygen delivery. And that those units of blood that we use to try to solve the anemia and improve oxygen delivery are also delivering acute kidney injury when we transfuse. So what can we do? What would we recommend regarding oxygen delivery? I don't think the final recommendations have been written on this, but if I had to come up with recommendations now, I would say number one, treat preoperative anemia aggressively. Since anemia is a problem, but we know a blood transfusion is a bigger problem, try to avoid going into the operating room with anemia, and don't treat it with a blood transfusion, but treat it with erythropoietin, IV iron, B12, and folate. No matter how much time you have, it's beneficial, even if it's just the day before. Limit hemodilution, which miniaturized circuits do very well, and I think is a good technique. You can also use retrograde autologous prime, venous autologous priming, cell salvage. You can use other techniques as well, like ANH, and you can use these techniques in combination if you're facile with them. Targeted DO2 around 280, but do so by increasing pump flow. And finally, I would advocate not to transfuse packed red blood cells to treat anemia, because it's a situation where the solution can be more harmful than the problem. Thank you.
Thank you very much, Ron. So with this great presentation. So I'm here with Dr. Nalbanti, intensivist from Greece, and Dr. Merkin, anesthesiologist from Canada, and they will probably ask some questions.
Thank you for your presentation. Maintaining the optimal DO2 through fluids, inotropic agents, or vasopressor is crucial for the patients, and very important for us in the ICU. As intensivists, we don't know about all this, about perfusion in the operating room, but we face all the result of them. When the perfusion is right and the surgical procedure is the best you can, for us, we have to do, we have to face less complications, and the outcome of the patient is the better it could be. Thank you.
Thank you. John?
I think that's a very important recommendation, the pump flow to increase oxygen delivery. I think we've known for a long time, as you point out, the adverse effects of allogeneic transfusions, and whatever we can do to avoid that is key. And understanding, again, that we need to provide sufficient substrate delivery to tissues by increasing pump flows where possible, I think is a major, what's the word, important aspect that I don't think we've emphasized enough, which goes along with all of the other steps to try to avoid the anemia in the first place. As you say, that's part of the ERAS program, trying to optimize hemoglobins before we get started. And similarly, the limitation of anemia, of hemodilution. And certainly for, I think, most anesthesiologists these days, I think, are very tuned into this to try to minimize the amount of fluid, exogenous fluid administration. And similarly, miniaturization of the circuit, so all of these components together. But I think, as you've identified, it's as much the actual transfusion itself that I think is harmful, and that's been a message that's been out for quite a while, and the ability to understand that and focus on other strategies is important. So, yeah, thank you.
Thank you. And Ron, I also asked Mike before, so since this society is minimally invasive extracorporeal society, circulation society, so I want to ask, we always discuss about the low penetration rate of the MiECT systems in US. As a surgeon, what do you think about that? What are the barriers, or why is it like that?
Well, I think you're right. I don't know why in the U.S. it's not one of the techniques that have been more adopted. The people have gone to using smaller tubing, but that's not exactly the same as a miniaturized circuit. And I don't know if we need more data to show the differential effects of miniaturizing your circuit versus doing autologous prime versus A&H, for example, because there's probably 4 or 5 good techniques to avoid hemodilution. And one of the questions I wonder about is, are you better off just doing 1 or 2 of them aggressively, or should you be trying to do all of them, or which are comparatively more effective? And I think some data on that may increase the adoption of miniaturized circuits.
Thank you. And there's Dr. Ashrafi from Germany. He's a surgeon. He also wants to ask you a question.
Actually, I'm a surgeon and a critical care specialist, so I have a provocative question. I totally agree with flow, and flow is more important than your hemoglobin, and it's a matter of oxygen delivery. So when do you transfuse?
It's a good question. I have the answer for me, but I don't have the answer that I can say is 100% correct, because as Dr. Grant alluded to, we don't know the perfect physiologic trigger or threshold for transfusion. We only use anemia, which is really doesn't tell us what's going on inside the cells. So what we do at our program, we're very restrictive. So we essentially only have 2 indications to consider a transfusion, and they're not triggers, they're thresholds for a discussion. One is if a patient is actively bleeding. And as you know, I think that's the most justified reason to transfuse. But as you know, not all of those patients need to be transfused. Sometimes a prompt re-exploration will solve that problem. And then the other, if someone gets to a hemoglobin under 6, we consider a transfusion. But we try to look for a physiologic reason, like a base deficit or some other sign of real end organ malperfusion. And basically look at increasing lactate or increasing base deficit.
Thank you very much.
Thank you, Ron, for your presentation and talk. Thank you very much.
Thank you.
And now the next speaker is Amanda Ria, again from US, is a clinical manager. Hi, Amanda, how are you? And she's going to talk about, again, a guide to goal-directed fluid therapy. Yes.
Thank you so much. Thank you so much for having me. I was a little bit paranoid about connection, so I did pre-record this talk that I'm going to share with you now. I kind of look at goal-directed therapy kind of like part of a book. Can you see my screen?
No, not yet.
All right. Let's try here. Oh, there we go. There it goes, I believe. Got it now?
Hello, everyone. My name
Yes.
is Amanda Ray, and I'm a nurse practitioner with the Division of Cardiac Surgery at University of Maryland, St. Joseph.
You lost again, Amanda.
Let's see here. Share, present, share.
Ah. So you probably press the stop button.
Okay.
They say that may be the reason.
All right, it should be getting ready to go here now.
Yes.
Hello, everyone. My name is Amanda Ray, and I'm a nurse practitioner with the Division of Cardiac Surgery at University of Maryland, St. Joseph Medical Center in the USA. I want to thank the organizers for inviting me to speak to you today, and we'll be talking about a guide to goal-directed therapy. These are my disclosures. First, I want to talk about the fundamental concept of goal-directed therapy, or GDT. And ideally, we want to match the patient's needs with treatment. individualize the administration of fluids, vasopressors, and inotropes, but in a standardized way. What we hope
Can
to
you
achieve
press the hide button, Amanda?
is assure that we have perfusion adequacy. We want to avoid utilization of patients' reserve and optimize their recovery and outcomes. Essentially, we would like to give the patient the right thing at the right time. GDT also allows us alternatives to the PA catheter. We're able to have less or non-invasive monitor availability, especially for lower risk patients. And these algorithms should be guided by stroke volume or stroke volume variation. One of the things you likely hope to achieve with a goal-directed therapy algorithm is a reduction in AKI. We know that cardiac surgery patients specifically have areas of mechanisms of insult that can attribute to AKI. And those are things like extracorpuscle circulation and perioperative drugs, low cardiac output syndrome, embolisms, and obviously bypass. Research for cardiac surgery patients has been building in recent years, although we still lack a large randomized control trial. Peer-reviewed literature, however, has showed reductions in length of stay for ICU, as well as total length of stay, morbidity, AKI, and infection. Also, the Enhanced Recovery Guidelines from the ERAS Cardiac Society, published in JAMA Surgery in 2019, listed goal-directed fluid therapy as a Class 1 Level B recommendation. So if we look at some of the literature, this meta-analysis that was done by Chung looked at over 11,000 patients and found a reduction in morbidity and mortality, specifically pneumonia, AKI, wound infection, and hospital length of stay. This randomized control trial had about 120 patients and showed a reduction in 30-day major complications, specifically infection, as well as low cardiac output syndrome, as well as ICU and hospital length of stay. Thompson looked at 260 patients and found a reduction in ICU and hospital length of stay, as well as AKI. Ganot found a shorter ICU length of stay, as well as vasopressor dosing. This study showed in ICU length of stay, it was about 100 patients. And lastly, this meta-analysis found a reduction in post-complication rate as well as hospital length of stay. So these studies help highlight the importance of goal-directed therapy, which includes reduction in AKI, shorter length of stays for the patient, reduction in infection and vent hours. The other thing that you're hoping to achieve is to maintain euvolemia as much as you possibly can and reduce the amount of hypervolemia that is unnecessary to a patient. This will reduce pleural effusions, pulmonary edema, AFib, as well as not having patients who are under-resuscitated and maybe with low blood pressure, low cardiac output syndrome, or orthostatic hypotension. We utilize a nurse-driven algorithm with 250 cc boluses at a time, and our personal algorithm that's listed here is driven by stroke volume. There is also a QR code, if you notice in the lower corner, that has about 10-ish published GDT algorithms that are guided by stroke volume variation. I think there's even one that's driven by CVP, so that hopefully it's something that you can utilize with whatever equipment that you may have at your facility. So let's talk about some implementation barriers that you may come across. Likely your staff may have a satisfaction with the status quo. They think things are going good as they are. They may feel a loss of autonomy or flexibility, especially if you're having a standardized algorithm when they previously chose more individually what happened with the patient. They would have an interruption in their current workflow, especially if you're talking about new equipment. They may have cognitive overload or temporary incompetence. And then you also have to prove to your C-suite the value of what you're doing. So let's talk about some potential solutions for these limitations or barriers. So you want to get preliminary data and audit that data, compare your results once you've implemented goal-directed therapy, and tie those to numbers to help prove to your C-suite for any equipment you may need. You want to get early and continuous stakeholder input. You want to give comprehensive education and discussion sessions. And when, like implementing anything, you want to reach everybody and every person so they understand and everyone's on the same page. You want to make your algorithm as user-friendly, pragmatic, and non-threatening as you can, and make sure no one is variating from that algorithm when you're trying to assess if it's successful or not. Just for an example, I thought I'd bring you a little bit of data from my facility when we were starting goal-directed therapy here. Our retrospective cohort was around 129 patients, and the GDT cohort was 222. We chose to use isolated patients with the EF of 45 or greater when we were initially testing the goal-directed therapy algorithm, just as a cost-cutting measure. We found a reduction in 4.7% of our post-op 2 AKI, a reduction in 2.1% of our post-op 7-day AKI, and a reduction in 2.6% of our average discharge AKI, and that is by KDIGO criteria. We also found a reduction in 7% of our atrial fib rates. Albumin was not on our algorithm, but seemed to be occasionally used, so we definitely found a reduction in our albumin usage. But we also found that we were giving about a liter more of fluid to our patients post-operatively, and we looked at IV fluids in a 48-hour range post-operatively. We didn't find much difference in our vasopressor hours. However, where we did find some significant changes were we had about a 10-hour reduction in our ICU length of stay. Our ICU readmission rate was reduced by about 1.3%. Our average post-op length of stay was interesting to me because the average for these patients is about 7.8 by STS risk-adjusted metric, and we already are well below that average at 5.6, so we were still able to reduce it by about half a day. And the largest change we saw was reduction in hospital readmission. Before starting GDT, we had a 13.2% readmission rate, and we brought that down to 0.5. And when we had looked into that readmission rate before we started GDT, we found that most of our readmissions were related to some type of volume overload. Pleural effusions, could potentially be AFib, or pulmonary edema. So I want to thank everybody for listening to this presentation. And again, thank you to the organizers for the invitation. If anyone has any questions, feel free to email me. I'm happy to share order sets, algorithms, whatever I have. Thank you so much.
Thank you very much, Amanda. Any questions? No? Okay, so I want to ask, so in order to organize the goal-directed fluid therapy, so do we need really any monitorization techniques, or we can use any methodology without the help of the new technology, for example?
So I think ideally you have a device that can give you stroke volume or stroke volume variation. Rather that comes to be a continuous PA catheter or a minimally invasive device. There are even algorithms. You can start by using almost a poor man's algorithm, and there's algorithms. Some of the ones I listed in that QR code are driven by CVP and cardiac index. So I think you can do it even if you have a PA catheter, but obviously, ideally, most of the data is between stroke volume or stroke volume variation.
Thank you. Okay, so thank you very much for your presentation. Bye-bye.
Thank you so much for having me.
So is Christian Stoppe connected? Ah, okay.
Yes.
Hi, Christian. Hi, how are you?
Hey, good to see you. I'm pretty good. Yeah, thank you for having me. It's a big pleasure to be at least virtually here, although I would have preferred to be there in person. So my sincerest apologies, and thank you.
Thank you. So Christian Stoppe is an intensivist in Germany, very much do a lot of research on nutrition. So we're going to listen to him about the nutrition in cardiac surgery. Thank you.
All right. So I'm going to share my screen. So let me do full screen. So can you see my full screen? Yeah.
Yes.
Okay. Thank you. All right. So it's my pleasure right now to talk about one of the, after we have talked about the single components, to talk about one of the, from my perspective, most under-recognized aspect within the perioperative care. It is just the nutrition support in our patients, and I will lead you through all of this by talking about the preoperative phase, the intraoperative phase, and the postoperative phase, because within all of these windows, we have specific problems and strategies how to overcome these problems from the nutritional perspective. And I thank Seda very much for outlining the relevance of malnutrition in this patient, which is one of the really significant problems which we more and more consider. So let's start with the preoperative phase. So we know that the nutritional status of our patient, but as well the reduced oral intake in our patients, especially in the elderly patients, is of high relevance. And starvation is another problem, because surgical procedures are rescheduled from day to day or to the next week, etc., leading to a significant starvation in our patients. And we have to critically ask ourselves if we can expect that really all patients have the same nutritional risk and all patients benefit from our nutrition intervention. And to do a rigorous risk stratification with respect to the nutritional risk is actually recommended by the different nutrition guidelines, the American guidelines, European guidelines. We have our own guidelines in Germany. So then all of them uniformly recommend that a nutritional risk stratification should be done. And even the ISHLT is giving a recommendation for that. And when looking into what is already established in the more general surgical patients, we know that there exist already like well-established pathways. So when you know which are established in the clinical practice, so when you identify patients who are malnourished, such patients should be scheduled. So the surgery should be rescheduled, and a preoperative optimization program should be done in these patients. And the nutritional assessment is very easy. It's basically it basically considers the BMI, the unplanned weight loss, and as well the albumin level, which we see more and more in different risk scores, although I'm very critical about that. It's just a fact. And when we have once identified patients at risk, it's recommended to reschedule the surgery and to schedule a preoperative optimization program. So what is known for cardiac surgical patients? So when regarding our existing guidelines or recommendations for cardiac surgical patients, a preoperative measurement of albumin for risk stratification is recommended, although all of this is based on a rather moderate level of evidence due to not really strong large-scale RCTs in this area. A preoperative correction for nutritional deficiency is recommended and should be done whenever feasible. And a preoperative carbohydrate loading is as well recommended, which is based at the moment on a low level of evidence, and certainly more evidence is in this area needed. And we try as well to contribute to this level of evidence, and we are not focusing here on the all-day patients like the bed and breakfast patient who just stay one day on the ICU. We here in our studies, for example, focus on a specific vulnerable patient cohort, such patients that are scheduled to receive an LVAD implant, because here we can do the preoperative optimization strategy in patients who are already in the hospital. And this is a patient cohort that has a high likelihood to benefit from a nutritional intervention. And then we hope to learn from these patients and to transfer the learnings back to the more general population. So what is known from the intraoperative phase, from the nutritional perspective, inflammation, ischemic perfusion, the surgical trauma can eventually be attenuated by immune modulating agents and micronutrients. And we know that the inflammatory response is a major driver which contributes to the development of organ dysfunctions that necessitates a prolonged ICU length of stay. So for that reason, a lot of little pilot trials, smaller trials, investigated different anti-inflammatory and antioxidative strategies. And as such, we as well recently published a large-scale RCT, which was conducted in Canada and in Europe. So hello to John, by the way. And as such, we randomly assigned patients where we thought that they were at high risk or increased risk for postoperative complications to receive preoperatively a loading dose of an anti-inflammatory strategy. Here was a high-dose sodium selenite administration, followed by a high-dose sodium selenite administration, which was continued after surgery and while the patient was on the ICU. However, the primary endpoint was very disappointing. When we received, like 5 years later, the overall results that we received from over 1,400 patients, then the primary endpoint, the freedom, so the ICU dependency, did not differ between these patients. So this was a composite endpoint that with persistence, the composite endpoint called persistence of organ dysfunctions within 30 days, and it was very sensitive. And we failed to demonstrate a clinically meaningful benefit in these patients. Eventually, there was an effect when considering the early perioperative phase, because patients that received the high-dose selenium supplementation had less organ injuries during the very acute phase after surgery, but this effect disappeared over time. As well, the secondary endpoints were not encouraging or did not identify some promising effects in these patients, whereas the subgroup analysis at least indicated that patients that were frail or such patients that had really a prolonged CPB time eventually showed a tendency to favor more from the high-dose selenium supplementation. So why did this happen? We are currently doing a lot of subgroups, secondary analysis, post-hoc analysis to get more answers about that, because we do just want to continue. And one of the answers which I would like to share with you is the answer about like which patients belong to the vulnerable patients, which patients should be on our focus. And as such, I'm happy to share this unpublished post-hoc analysis that identified that patients that were elderly, that showed signals of frailty, so which had urgent surgeries and which had a higher Euroscore or in the end prolonged CBB time, that these were identified as a high-risk population, which we know as well from other data. But even when combining at least two of these factors, we received a very good predictive accuracy for the development of organ dysfunctions and death during the ICU length of stay after surgery. So we want to take these learnings right now, and I'm very happy to be in contact as well with Professor Gunaiden about that, to eventually test following next compelling anti-inflammatory strategies in these patients to contribute to the resolution of inflammation, because we know that inflammation per se is important for our patients. We don't want to block it per se. We just want to modulate the perioperative inflammatory response in our patients. So let's talk about the postoperative phase, when our patients are admitted on the ICU. So what do we know about nutrition practice? We recently published the results of an international nutrition survey, an observational study, which was conducted at cardiac surgical ICUs worldwide, and the nutritional data and outcome data were captured in patients and cardiac ICUs from Canada, the US, Germany, Russia, Iran, Malaysia participated in these observational studies, and we assessed the nutrition practice on the ICU in these patients. And this is really a highlight, which I have to share with you. So the blue dotted line demonstrates here so this picture demonstrates the adequacy of energy input, and the dotted line indicates the target goal for nutrition. So the nutrition targets which should be achieved based on current guideline recommendations. On average, this is the blue line, the patients received with significant delay the recommended nutrition targets, whereas the worst side, it's the red line, never ever nearly achieved the nutrition targets, whereas on the other hand, the black line demonstrates that achieving nutrition targets is doable. And the problem is, if we do not achieve our nutrition targets, it leads to significant deficiencies, that leads to a significant loss of muscle mass in our patients, that in the end influence the functional recovery in our patients. So when patients are discharged from the ICU, we have to think more, not only about the survival in our patients, we have to think more about the quality of life in our patients and the functional recovery in our patients. And the same holds true as well for the protein target. There were significant deficiencies illuminated in our patients, so there exists a knowledge gap in nutrition practice, which we have to improve. So what are the reasons for that? And I just briefly want to touch on this. So the timing for initiation of enteral feeding, for example, showed a high variance across sites. So on average, it was EN was started after 2 days. So whereas it's recommended to be started within 24 to 48 hours in the general ICU patient when the patient is hemodynamic stable. The other reasons were that a lot of interruptions were observed in these patients. And this is what we all know as clinicians, which is happening. So we are reluctant to ramp up enteral feeding, or when the patient is on high dose vasopressors, we are reluctant to be too aggressive with our enteral feedings, but we do not have strategies to compensate the potential resulting deficiencies. So, and sometimes there's a CT scan planned in the morning, the feeding is stopped, but the CT scan is happening in the afternoon. And we never think about how to compensate the resulting deficiencies in our patients. So potential strategies to overcome that is to think more about the timing, as briefly outlined before, and as well to think about strategies like the use of supplemental parental nutrition as a combined strategies to avoid such deficiencies. So when you want to rather protect the gut, you are anxious about some complications in these patients, which, by the way, are not really objectified when looking at the literature, you can think about the use of supplemental parental nutrition to avoid the potential deficiencies. So how to bring all of this together? So for your clinical practice, for your patients at home. So here, this infographic illustrates the early phase after admission to the ICU, 24 to 48 hours, and the post-acute phase. We know that the hemodynamic instability, the surgical procedures and interruns leads to a lot of interruptions when considering the feeding strategies in our patients. And here, the first point is certainly that we have to be aware of that. We have to think and look back at our patients yesterday achieve our nutrition goals, which we have set. So have we do something to improve that? We have to focus on the right patients. So does our patient has potentially a prolonged ICU length of stay, so more than 1 day? So then he or she is certainly a high-risk patient, so which should receive an intense nutrition support. We have as well to think about if the patient is extubated, or about a reduced oral intake or appetite in our patients, or about dysphagia, which is relevant as well in the elderly patients. And then we have as well to think about the critical illness in our patients. So when our patient is on high dose vasopressor, has signs of inflammation, etc., it's maybe really not the time to achieve full nutrition support, but this is the only contraindication in your patients. And then think about how can you optimize your feeding? How can you really achieve your nutrition targets, which you have set the day before in your patients? And if all of this doesn't work, think about the concept of supplemental parenteral nutrition to avoid the potential deficiencies. And then the last point is exercise. If you think about the people who are going to the gym, or else they do not just go to the gym and drink the protein shakes, they do exercise and are drinking the protein shakes to really try to contribute to the gain of muscle mass, or here in our patients to prevent the loss of muscle mass. And we can only achieve this goal if we combine nutrition support with exercise in our patients. And then the last point is monitor the success of your intervention. And it's very easy to do that. Think more about potential outcome measures, which your physiotherapists are eventually already doing, like the hand grip strength, the 6-minute walk test. There exists a battery of different things which you can easily implement in your daily practice, either in the intubated or in the extubated patients. Happy to share more information about that. And in the end, it's really important to add more quality to the life in our patients. We have overcome the phase where we were just focusing on the survival. Now we are really focusing more on the functional recovery, the quality of life in our patients. And by focusing on the nutrition support and exercise, I hope that we can do a significant contribution. And as such, we are as well doing a lot of research in this area. We are planning a new trial to focus on nutrition support and exercise, which will evaluate the functional recovery in our patients. And I'm happy to share as well that the ERAS Cardiac is partnering with international societies to establish new guidelines for perioperative nutrition support in cardiac surgical patients. I'm happy to receive any people who are interested in this topic to talk offline about that. And the last point is really that we have as well to focus on other patient populations, such with MCS support, in which this is certainly a risk group where we are more reluctant to think about nutrition support. It's really happening after patient is days on the ICU. And we as well try to give more guidance about how nutrition support should look like in these patients. And with this, I'm at the end of my presentation. With this little illustration, I just want to make clear that there exist a lot of gaps during the journey of our patients. So when the patient is admitted to the ICU, there are a lot of risks for when malnutrition may happen in our patients. So nutrition risk is a modifiable risk factor. So it's very easy to address that, to be aware of that, and to with nutrition support, we can really improve our patients' outcome. And we have to monitor the nutrition intake. We have to give guidance and feedback, and really focus more on this. And with this, I'm at the end of my presentation and very happy to take your questions.
I'm here with Dr. Nalbanti, intensivist from Greece, so she may be asking questions.
Hello. Thank you for the presentation. I don't want to make a question. I want to highlight 2 points about the use of supplements like selenium and the energy drinking or high carbohydrated drinks before 2 hours prior to surgery. I think that this is the difference about all that we know until now. Can you explain your everyday management of the patients there?
Yeah, so 2 points. We have problems with clinical trials in this time. Yeah, so like it's really hard to find any trial, any intervention, although I'm really very enthusiastic about research. It's really challenging to show that any intervention results in a clinical significant effect in large-scale RCTs. So this, when I'm telling you that the results were neutral, it is not the conclusion that the intervention doesn't work. It's really about we have to identify patients that may benefit from our patient. So when Professor Gunaydin is doing a risk stratification, he identifies patient with a nutritional risk, then this is a target population which should certainly receive the carbohydrate loading, the protein drinks, etc. You need to establish the standards to identify the patients and to start the nutrition drinks. The other point is, if you have, for example, a patient where you know this will have a prolonged time on this cardiopulmonary bypass, then you could think about the oxidative stress which is happening. So I cannot give you recommendations about that, but I know that a lot of patients, clinicians, and especially anesthesiologists care about that, how to attenuate the inflammatory response, how to attenuate the resulting oxidative stress, and here micronutrients, antioxidants might be a potential strategy in the future. Yeah. They're actually doing this. Yeah.
Thank you.
Thank you very much, Christian. Thank you for the presentation.
Thank you.
So we close the session. I know you're all tired, but that will be a very brief wrap up.
So the numbers are decreasing, but we still have half an hour to go. And it's a pleasure to announce our last speaker of the day, the president of the society, Professor Cedar Gunaydin. And I'm very interested in knowing how he sees our future.
So I start with the past. So when even I was a resident, I started research for cardiopulmonary bypass, inflammatory reactions. So at that time, it's really a very old times. And then we were focused on surface coating. So we started all types of research on surface coating. And then I got a scholarship to go to Japan for bioengineering PhD and pediatric cardiac surgery. So then I see the technology. You know, I was here, I jumped over here. I can easily tell you about the story. So they organized a kind of meeting with the industry. I saw the CEO of Terumo, the top guy. I asked him, I see here some products that I've never seen before. So are those products available in Europe? He says, no. I said, why? They cannot buy it. They are very expensive, he says to me. So even I see some cardiopulmonary bypass machines, oxygenators, even for pediatric at that time with very high tech. And then I received my PhD and I started to work again on surface coating. So we published some reports and I went to US and I worked with this guy, Kevin McCusker, and they were, at that time, it was 2000, and they were working on minimally invasive extracorporeal circulation. That was the term I heard for the first time at 2000. And then I started working with them, and we published the initial report in 2009, and this idea was patented at that time in the US. And so we started using these minimally invasive circuits, and then Terumo introduced the RockSafe system, and so we started to do research and start to do a proctorship for the RockSafe all over the world. So I also started working with the Hammersmith Hospital with Terry Gourlay. He was the responsible guy for all the technologies in Hammersmith, and so he was moved to Strathclyde University in Glasgow. So he's the top bioengineer guy, and then we published this book together on minimally invasive circuits in around 2010. So then I come back to Turkey, started again working on what can I do in minimally invasive extracorporeal circulation. So even in med school, I was teaching students that the cardiopulmonary bypass. So I always started the lesson like this. I just say, who is the best student in this class? Somebody says, I am. Okay, come here. So this is the year 2012, and you can go back to 1953. There is no information about cardiopulmonary bypass machine. How can you stop the heart of a patient? So even after 50 years, they know nothing. They couldn't stop that. They know nothing about heparin. They don't know to use some kind of anticoagulation. So it's really a concept that was even new for the medical students. And again, we gave structure and courses in perfusion school in the case of cardiopulmonary bypass, cardiac surgery society training for fellows and residents. And then in the proctorship, we just go all around the country, started some MiECT programs. It was very difficult. So, for example, we were going to some place that they have no idea about MiECT. We were setting up with my fellow perfusionists, and always we were in, incredible stress to finish the operation without killing the patient, because we were not doing the operation. We were watching and helping them. And of course, after every operation, we were going out for drinking to forget everything we lived in the last half an hour. And of course, for example, we did some kind of workshops in some society meetings. So once, and I worked with a German perfusionist, Uwe Schönrock. So we, for example, set up the MiECT system. They say, no, it should be live. You should put some red blood coming inside the circuit. I said, how can you find red blood in a hotel? So it was an Antalya hotel on the Mediterranean Sea, all inclusive. So I put wine, red wine, in the system. So we circulated red wine, and everybody was very much, impressed and understand the idea. So I also went to some Russian countries like Azerbaijan, Belarus, Russia to start the programs. And of course, at the end of every program, we just kept on going drinking to forget everything. So I have become an alcoholic before finishing this proctorship program. And again, Middle East and USA. So we really did a lot of things in USA. Unfortunately, always disappointment. And as I asked to Ron Selinger, so the penetration of this system in the US market was always very difficult. So I was, crazy. I couldn't do anything. I was trying, and no. So I remember Aristotle. He says, if things do not run out as we wish, we should wish for them as they turn out. So this is a kind of adaptation for me. And I see this. I was desperate. I couldn't do anything with MiECT. And then just for the first time, I saw this society, and then everything changed. Then, in this society, look at the aims, look at the realization of the aims. They all are my dreams, or were my dreams at that time. And I couldn't even find any other surgeon to discuss my ideas at that time. And suddenly I found 300 people to discuss. So that was really a paradise for me. And then again, we worked with the society, as they're all told. And with this society, remember Rumi is a Turkish philosopher. Everything about yesterday is gone with yesterday. Today, it is needed to say new things. So we go on the way like this. And this is dissemination curve of the new idea. So in the beginning, only visionaries do something, then pragmatists, and then conservatives, and then everyone. So it says it takes 17 years for a new innovation to be adopted in the clinical practice. So I told you, the patients are getting sicker, frail, so they need more help. And there's the evolution in the healthcare systems. We need to adapt this new evolution to value-based surgery or die. So again, with the conventional techniques, we come up to the modular CPB. We can do now anything in the hospital, everywhere, in any department. So the levels are going up. So this is our MiECT circuit. We started the pediatric program. We did only a few cases, but it's difficult, but we are forcing to do also these pediatric cases. We adopted minimally invasive case. We adopted ERAS protocols. We combined those protocols. And then MiECTiS also has gone a long way, as just already mentioned by Dr. Anastasiadis. We have nearly 500 members. We have comic studies, hopefully will be published very soon. We have a new study We have 12 meetings, video collections, 500,000 views. And the technology is improving, and they all have the option for minimally invasive circuit now. So this may be a good opportunity for us to go on. This is the surgery of the future. This is the last 2 cases I had in the last week. So this is TAVI valve in valve, stuck. Patient was dying. This is another valve in valve. And then they ruptured the aorta, and another emergency case. So in both cases, we just get out 2 valves and we put another valve in the same patient. So this is the surgery of the future. And this is the other surgery of the future, minimally invasive cardiac surgery. So everything is coming together for the promotion of the MiECTiS system much better than, let's say, 10 years ago. So the future of cardiac surgery will be dealing with such complications, plus with very frail, very difficult patients. This is all the patient population rest for us. Every other patient is already treated by interventional technology. So according to our constitution, the duties of president is like this, and I will try to obey all those. So we were going still on the comic subgroup analysis, so this is important for the near future. And we tried to force the MiECTiS to add some new centers, find some grants. Online training program is a very good opportunity. We discussed with the industry today. Hopefully we will do it. We will disseminate the ideas to all over the world, let's say, and to start with the new MiECTiS programs in some centers that are willing to do. Database and registry is important. So we already have the data of more than 1,000 patients. So we can produce any new papers from this data, I hope. And we continue to do meetings like this. So I also want to increase the number of members, countries, and especially because 48% is perfusionist in our member group. So I need to try to increase the number of surgeons maybe. So periodical newsletter will be helpful to disseminate this information and to keep people interested in this focus. And of course, cooperation with other organizations will continue. We also discussed to use social media to promote our ideas routinely with some certain time intervals will help much. And again, one-day training programs in different countries to promote the activities. And of course, to do all of this, I need my friends. I always do like to work with them. So as the Alexander Rate from here says, my treasure lies in my friends, all of my friends. But first, before finishing, I need to clap those 2 people, really. They really helped us. And the last slide. Yeah. And so, can you? Yes. And I finish again with our Aristotle. He says, whenever hope does not rely on the past, according to Aristotle, it degenerates into false optimism. But of course, our awareness of the past is not a mere accumulation of memories, but it's another cognitive achievement. It's called experience. And there is no hope without experience. So we have the experience and we have the hope. Thank you.
So thank you very much for this. Please remain standing. We have still the Medal of Honor, which goes past to the new president. And you're gonna receive that from John Merkin. I like 2 very important sentences in your presentation. First, that we're in our adolescence, so we can all feel younger again. And that your treasure is in your friends. And I'm very looking optimistically forward to your presidency. I hope that this will carry this organization a step further into adulthood. And I ask John to present you with the medal.
Yes, thank you. Thank you so very much. Again, I want to congratulate particularly the 2 key members of this society, really the founders, the visionaries, and the team that's now been assembled. And I think this has been a tremendously stimulating program. So I want to thank you both for this tremendous learning opportunity. I do have to say that unfortunately Cyril Sarek, the current president, is unable to make it. But Cyril did send me a package which he claims has the official gold medal that it's my privilege to hand over to the new president. So without any further ado, the envelope, please, and we'll find what's inside. Let me see if I can open this first of all. But it's been sealed, so Cyril is the one that is traveled well. Yeah. Oh, look at this. So there we go. The official medal. And it's my honor to hand this on to the new president. And wish you all the best.
So I have two little tasks before we end the session. First of all, I'd like to ask Professor Anastasiadis to come to the podium to end the session. And I want to share a few numbers with you that have been handed over. Obviously, we've had 340 registrations to this meeting. We had 420 live views through live media, and another 450 through CTSNet, with a complete number of views of over 12,000 views. I think this speaks for the success of this meeting, and I want to congratulate Kyriakos and Polychronos on their continuous efforts for this society. And to keep it short, you have the podium.
Just before ending, I need to express my sincere thanks to the sponsors and friends, especially Medtronic, who was the major sponsor for this event, but also Terumo, Livanova, Eurosets, Edwards, Life Motion, and Cardiosynergy, who contributed for being able to accomplish this 10th anniversary meeting of MiECTiS. I need to acknowledge and give my sincere thanks to Live Media, Inventix, with Stathis and all the guys behind all this for make it happen. Last, Polychronis. Where's all the job as usual. And of course, all the friends that are all these 10 years with us. It's very nice to have friends. And let's see how it went, this 10th anniversary meeting event, please. So I need to congratulate Professor Günaydin for his presidency. I wish him all the best, and I really appreciate all of you that you are here. So I invite you to follow the social events that are coming, and thank you for being with us. All the best. Yes, we will meet 2025 probably in Istanbul, definitely in Turkey, but you will hear about this soon because we are collaborating. President and Vice President will let us know, but probably will be next summer or end spring in Istanbul for our update meeting. So thank you.